लिस्ट देना सर, नामों की लिस्ट देना डॉक्टर साहब, सेकंड पेज नाम लिखवाना। Good morning, everyone. I, Dr. Manu Priya, Associate Professor, Department of Pathology, welcome you all for today's virtual CME on update molecular pathology. First, to begin with, I would like to welcome our worthy Director Sir, Professor Dr. Veer Singh Negi. It has been only because of his constant support and encouragement that we were possible to conduct this today's CME. Next, I would like to welcome our respected Dean Sir, Professor Dr. Sanjay Vikrant, for his constant encouragement and support. Next, I cordially welcome all our distinguished speakers, Dr. Abhishek Purohit from AIIMS Jodhpur, Dr. Anchal Kakkad from AIIMS New Delhi, Dr. Pariksha Gupta and Dr. Prateek Bhatia from PGI Chandigarh. I also extend my warm welcome to Dr. Dipanjan Haldar from Jupiter Hospital Thane, Dr. Anita Tehlan from GMCH 32, Dr. Nalini Gupta, PGI Chandigarh, Dr. Rajiv Kaushal, Tata Memorial Hospital, Mumbai, Dr. Pulkit Rastogi, PGI Chandigarh, Dr. Poojan Dogra Marwaha from AIIMS Bilaspur, and Dr. Darwin Kaushal from AIIMS Bilaspur for accepting our request to be the chairpersons for today's sessions. It is my humble duty to thank all our worthy speakers and chairpersons for having gracefully accepted our invitation and taking out time from their busy schedule. Last but not the least, I am very glad to welcome all our participants in this virtual CME titled Update on Molecular Pathology. It gives us immense pleasure to see the enthusiasm among our audience as we can see a number of registrations from all over India as well as from abroad. Today's CME has been set with an aim to update our fraternity regarding the role of molecular pathology in different domains that include hematology, head and neck cancers, and techniques involved in endometrial carcinomas. Needless to say, the role of molecular pathology has increased in leaps and bounds in today's era and has become an essential tool for diagnosis, patient management, and disease monitoring. I hope all the delegates will be benefited from today's event. I request all the participants to actively participate in today's CME and please write all their questions and the feedback in the chat box so that we can know what are their opinions for the young residents will enthusiastically participate in the online quiz with an eye on the prizes and ear on the essence of knowledge. Once again, I heartiest welcome you all. Thank you. Now, we are going to start with our first session, which will be given by Dr. Abhishek Purohit. I welcome you.
Good morning, all. I welcome you all speakers, chairpersons. So now starting with our session, I would like to invite our first speaker, Dr. Abhishek Purohit. He did his hematopathology DM from All Institute of Medical Sciences, additional professor in the Department of Pathology in AIIMS Jodhpur. And sir, areas of interest is hematology, thrombosis. So this session will be chaired by Dr. Dipanjan Haldar. Sir did MD from PGI Chandigarh. Sir is a gold medalist in DM clinical hematology. In addition, Sir also did a fellowship leukemia from BMT Vancouver, Canada. And Sir was a visiting physician in the Fred Hutch Cancer Research, Washington. And currently, Sir is working as in Jupiter Hospital, Thane. Other chairperson is Dr. Turjit Rastogi. Sir is currently working as assistant professor in the Department of Hematology in PGI Chandigarh. And sir did his MD and DM hematopathology from PGI Chandigarh. And sir has about 51 publications both in national and international journals. And sir areas of interest is molecular hematology of myeloid neoplasm and laboratory automation. So I would now invite Dr. Abhishek Purohit to start his presentation. Uh, Abhishek sir. Dr. Abhishek.
Hello.
Thank you, Dr. Manupriya. I thank the whole organizing team for inviting me to the update on molecular pathology initiative by Dr. Manupriya and her team. I thank you. And now I would start. I think I'm audible, Dr. Manupriya. Dr. Manupriya, am I audible? Dr. Manupriya, am I audible? Am I audible? Thank you.
Yes, sir, you're audible.
Okay, I was just afraid of this thing. So I thank again organizing committee for inviting me. So now I will start with role of molecular diagnostics in hematology. So I started thinking about this topic. It took some time how to go about this. Today's time when we have lots of information to summarize everything in 40 minutes may not be very easy. So I tried to understand it in my own way, and in next 35 or 38 minutes, our learning objective will be to understand the golden circle of molecular diagnostics in hematology. That is why, how, and what. What we do, why we do, and how we do. That is very simple, but we insist on making it complicated. So first we start with the simpler part. We dissect the title of the talk, that is molecular and hematology, and the role. Three parts are there. So if we start with hematology, in our country, there have been description of hematological disorders in Atharva Veda some 2008 years ago. In Western part of the world, people started acknowledging cancer. They discovered cell in 1665, described human RBCs in 1674. Verco was the one who described the triad of thrombosis as well as described leukemia in 1847, type 2 type of leukemias. Newman was the one who told that marrow is the source of blood and leukemia is a disease of marrow. It was Ehrlich who made hematology a colorful field with development of stains. And from that time onwards, since last 150 years, we have been looking at various colors of hematology. In 1900, Nagelai described about the myeloblast and lymphoblast. So in last 120 years, there have been developments from identification of blast now to the, we have gone to the molecular level. So the journey of molecular diagnostics has also been very interesting. We can see how purification of DNA was done in 1866. It took almost 90 years for identification of sickle cell anemia mutation, and structure of DNA was identified in 1953. Sequencing was done in 1977, and the landmark thing was Human Genome Project. So next we will talk about the word role. We know Amitabh Bachchan, we have been seeing him since last 54 years. He has changed, he has groomed, his role has emerged more stronger with time and indispensable today in the even today in Hollywood. So similarly, in WHO classification and the recent update that was published in June 2022, we can find that the molecular pathology and the molecular diagnostics, these are now indispensable. Not only mandatory, essential, we may not be able to diagnose many things without molecular pathology. So the role is changing as well as it is emerging more and more. Again, if we talk of hematology, hematology has been described as the burst forming unit, which has given rise to various disciplines of medicine. So it's very important that hematology took the maximum advantage. It has remained on the forefront of all medical sciences to use molecular pathology. So we now move to how we do it. Very quickly, I will discuss that there are various methods, like we start with nucleic acid isolation, nucleic acid hybridization, sudden blotting, amplification of nucleic acid with the help of PCR, reverse transcriptase PCR. We do detection of amplified DNA with gel electrophoresis, cleavage-based signal amplification. We do real-time PCR. We have been doing then nucleic acid sequencing. The last in the armamentarium is next generation sequencing, but there are many more to come up. So how we started that the DNA is a simple double helical macromolecule, and RNA polymerase transcribes DNA strand and forms mRNA, which contains coding sequences called exons, and introns are non-coding sequences, and these are spliced, and mRNA then moves to the cytoplasm, and ribosomes, they translate mRNA into proteins. This picture showing various DNA nucleotide structures, how DNA polymerase acts, complementary strands of DNA, and structures of purine and pyrimidine. On the left, we can see a DNA replication, which occurs with the help of primases, primers, and DNA polymerases. On the right side, we can see the basic technique, which may not be used nowadays, sudden blotting. In this, what we did was we did cutting of DNA by restriction endonucleases, separation by agarose gel, transfer to nitrocellulose filter, hybridization of probes, autoradiography was used to look for the bend. So this was the very first technique where we used molecular methods to identify various bands of DNA. On the left, what we can see is the application of PCR to target beta globin DNA amplification. On the right now, what we can see how BCR-ABL1 chimeric mRNA is formed because of the translocation between chromosome number 9 and 22, and then reverse transcriptase PCR produces cDNA from this mRNA, and then we detect the BCR-ABL mRNAs with the amplification of cDNA. On the left, DNA gel electrophoresis on a slab, gel is shown. Left, we can see why I'm showing all these things. These are the basic warming up thing for knowing more and more things in the subsequent part of the talk. Now, on the left, what we can see is the molecular ladder, a size marker. Positive controls are shown in the B. C is negative control. D is having no DNA. So with this, A is kind of landmark or the molecular markers. If we are getting any bend on this gel, we can look at, we can compare with the molecular ladder and identify the type of bend of DNA. The right side showing electropherogram of capillary gel electrophoresis. It is showing, we can see that there is separation of fluorescently labeled DNA fragments by size. The size of base pairs is increasing. The simple factor 5 lead-in gene mutation, how it is detected with the help of PCR restriction fragment length polymorphism technique. In the uppermost panel, A, what is shown is there are two restriction sites. These are the sites, cleavage sites, where enzyme X, restriction enzyme X, and it cleaves it into three parts. We are using these enzymes, and it cleaves into three parts: 82, 37, 104 base pair. If a person is having mutation in this second site, what will happen? It will be this site only will be cleaved, and what we will get? 82 size and the 141 size base pair product. So if we are getting two products, we can say that the person is having homozygous state of this mutation. In a person who is heterozygous for this mutation, what we will find that one will be normal, having two cleavage sites, and three products will be formed. In the other chromosome, there will be one loss of one cleavage site and two products. So ultimately, four products will be formed. So if three products are formed, person is normal. If two products are formed, homozygous condition, and if four products are formed, this is heterozygous state. So it's simple, but we need to learn. On the left, we can see real-time PCR amplification curve. Try to focus on CT values, threshold values, exponential phase. On the right side, we can see qualitative real-time PCR for detection of mutation in hereditary hemochromatosis. This is also a hematological disease. We are using two TechMan amplification probes, and this is allelic discrimination plot. It is showing three type of populations. Similar thing can be seen in real-time PCR amplification curve. We can see two types of curves are seen, one for wild type, one for mutant type. From here, we move to a much commoner application in our field, that is BCR-ABL1 amplification and its detection by quantitative PCR. A and B, these are showing curves for series of standards. Those who have been doing fibrinogen testing, they might be knowing just a basic thing that we use various standards, we run them, and we form a standard curve. Similarly, standards are used in this application also. And what we are doing, we are running them, we are making the curve, and we are getting their copy. We know their copy numbers, we take their CT values, we form a standard curve, and then patient's sample is used. Four samples or three samples are used in this picture. And on the left, we are looking at BCR-ABL1 amplification. These are transcripts. BCR-ABL1 transcript. This is control gene, ABL1, GUS-P, or any of these can be used. And we get their copy numbers from the standard curve we have already formed. Then we take BCR-ABL1 and ABL1 ratio, and then with the help of conversion factor, we get IS score, international score. This is similar to international normalized ratio, which we use in prothrombin time. This is for harmonization of laboratories. Next is Sanger sequencing. It is cyclic sequencing of DNA template. Generally, two methods were used: dye-terminated method and dye-primer method. Then lower down, we can see capillary zone electrophoresis. These fragments which are produced in the process, they pass and peaks are produced, and with each peak, we can find that it is a terminal nucleotide in the sequence. So this is how we do sequencing. Last, which is the next generation sequencing. I will rest my case here, and I would request Dr. Pratik to discuss about it in his talk. He's an expert for this. Next, what? Role of molecular diagnostics in hematology. What we are doing? We do it for diagnostic purpose, for prognostic purpose, for knowing some predictive roles of these molecular markers. There are various diseases. We can divide them accordingly, like major hematological malignancies for diagnosis of acute leukemia, myeloproliferative neoplasms, for myelodysplastic syndromes, and for monitoring of minimal residual disease can be done. When we are talking about neoplasms, in inherited hematological disorders, this may not be required at present, that yes, this mutation is required for the final diagnosis. Many are not using, but they have a role like in erythrocyte disorders, for thalassemia, membrane abnormalities, enzyme deficiencies, leukocyte disorders, platelet disorders, in bone marrow failure syndromes, in thrombophilias, and in bleeding disorders. The next common application is pharmacogenetic testing of genetic variation which is affecting therapy. Less commonly discussed are warfarin sensitivity, clopidogrel sensitivity, thiopurine sensitivity. Those clinicians who are dealing with acute lymphoblastic leukemia, they generally get thiopurine sensitivity done. And the most important is imatinib resistance. When a patient of chronic myeloid leukemia is treated with tyrosine kinase, that is imatinib, patient frequently develops certain mutations which may cause resistance to imatinib, and then these resistance analysis by mutations is also done because there is development of several mutations which are resistant to imatinib and other tyrosine kinase inhibitors. Then we can also detect various pathogens by molecular methods. So we now move to next slide, that is diagnostics. We can do one thing that we discussed, some of myeloproliferative neoplasms, how these are important. We have been reading these things since ages, since like 10, 15 years. These are mentioned in our criteria, but how commonly we are using, we do not know. A case can be just a neutrophilic leukocytosis, persistent neutrophilic leukocytosis, and he has been worked up, no reactive cause found, and we can presume that yes, this is a chronic neutrophilic leukemia, but until we do all these molecular testing, that is BCR, ABL testing, testing for JAK2, rearrangements of PTGF, RA, RB, FGF. We may not be able to diagnose the case as chronic neutrophilic leukemia. So if we go by criteria, we have to use molecular testings. A case of polycythemia generally present with blurry vision, itching, headache, and hypertension, bloody complexion. Some cases may present incidentally in bone marrow. We can see panmyelosis, but we require presence of JAK2V617F mutation or JAK2 exon 12 mutation, which are found in almost 90-95% of these cases. And this is a major criterion for diagnosing polycythemia vera. Similarly, in a case of primary myelofibrosis, patient can present with massive splenomegaly. There might be leukoerythroblastic blood picture. We can get bone marrow examination done both in pre-fibrotic or fibrotic phase. We know morphology, but we require testing these molecular markers. We should start with BCR-ABL1, JAK2, calreticulin, MTL mutation. They are not only for diagnosis purpose, at times they are also important prognostically, like those cases who are having calreticulin mutation, they are having less chances of thrombosis in cases of myelofibrosis in essential thrombocythemia, and we need to do some clonality assays. So next is a case of essential thrombocythemia. As the peripheral blood picture is showing, there is thrombocytosis in bone marrow. We get staghorn type of megakaryocytes, hyperlobulated giant megakaryocytes, isolated proliferation of megakaryocytes in a normally normocellular bone marrow. But if we go by criteria, we have to rule out CML, polycythemia vera, myelofibrosis, and we have to establish clonality at some point. So here I would like to mention two cases which we found in last 5.5 years, where patient presented with very high thrombocytosis, minimal leukocytosis in the range of 14 to 18,000. Patient was worked up outside, JAK2 was negative. Still, they were labeled as essential thrombocythemia. Cases were reviewed here. Bone marrow was done, which was showing hypercellular, near 100% cellularity. From one morphological clue, we again started the workup from BCR-ABL1, and that came out as positive. Patient was labeled as a chronic myeloid leukemia, and he's under follow-up. He's doing molecular monitoring for BCR-ABL1. Eosinophilia, similar condition. If we are diagnosing, we are looking at a case of eosinophilia, we can rule out reactive causes. We can get stool examination for ovacies, peripheral smear examination for some parasites. Clinician can give him or her antihelminthic. But after that, if we do not use molecular markers, we may not be able to reach to a diagnosis of chronic eosinophilic leukemia or some other things which are myeloid neoplasms which are associated with certain fusion transcripts. Now, in June 2020, much discussed this article. Almost every PG student must have read this. What we have found that more and more emphasis has been again on molecular markers. New entities have been devised, like myeloid neoplasms associated with germline predisposition. Now they are entities, and for diagnosis, again, we require molecular markers. Like we saw in eosinophilia, if we do not do PTGF RA RB, FGFR, VMS, we may not be able to diagnose these cases, and missing these cases may result in missing treatment for these cases because these are they can be treated with tyrosine kinase inhibitors. Similarly, in myelodysplastic syndrome, we can see that now we have MDS with defining genetic abnormalities in SF3B1 and P53 mutations can be disease defining. Everything is changing with the development or advances in molecular pathology. If you look at classification of acute lymphoblastic leukemia, in B acute lymphoblastic leukemia, what we can see that the terminologies of translocations have now moved to fusion transcripts. More and more emphasis is on molecular markers, and there are many entities which are important like BCR-ABL1 like features and BCR-ABL1 fusion, which prior to molecular technology were just going unidentified. So prognostic role, molecular markers, they also have prognostic role. We can discuss, for example, in myelodysplastic syndrome, the impact of main prognostic markers on overall survival and time to progression to acute myeloid leukemia can be seen in this picture. On the left, a blue line is showing where we can see that the overall survival in cases of myelodysplastic syndrome with SF3B1 mutation is better than those compared to those cases where MDS is associated with the TP53 mutation or ASXL or SETBP1 mutation. So these molecular markers they also have prognostic role also. Moving towards some benign hematology, that is in thalassemia. PGs must be knowing that May 8th is World Thalassemia Day. Thalassemia, these are one of the most common inherited diseases in the world with the highest prevalence in the belt, which is shown here, starting from the Mediterranean region, then Middle East, and India, Southeast Asia, and part of Africa. If we talk about mutations, more than 480 mutations have been identified world over. However, few of them are found in certain locations. If we talk about India, around 70 to 80 mutations have been identified in India. And out of these 80 mutations, 5 or 7 mutations are the mutations which are present in almost like 90 to 92% of cases of beta thalassemia in India. We have been finding that there is still birth of thalassemia in certain Western countries. There has been very rigid control. In 2018-19, national policy on hemoglobinopathy has been advocated. Still, it is on paper. It is yet to come on paper. But there is an emphasis for prevention of thalassemia, how we can diagnose these thalassemia cases with the help of complete blood count, electrophoresis, peripheral smear examination, hemoglobin HPLC of cases combined with the parental hemoglobin HPLC. We can screen cases, we can diagnose them as heterozygous beta thalassemia. We may try to prevent birth of thalassemia major babies, which can be a psychological, social, emotional, financial burden on the society. But what is important is the prevention. So one more way is to do prenatal diagnosis. For prenatal diagnosis, we need to know molecular profile of the area, of the country, of parents, and we can do amniocentesis or chorionic villus sampling in around 10 to 12 weeks or 15 to 18 weeks, and we can do molecular detection, and we can say yes, baby is having possibility of thal major, may go for termination. More update in molecular diagnostics help us towards non-invasive prenatal diagnosis. Here, thalassemia cases, in these cases where thalassemia major baby is already in the family, maternal plasma cell, cell-free DNA can be used, and diagnosis of the thalassemia major can be done in the baby, and appropriate action can be taken. People have been using some more things like population-based parental haplotyping because invasive is having problem of invasion. Non-invasive prenatal testing, it is time consuming. It can be it may not be cost effective at times. So population based haplotyping is one new thing which people in eastern part of Asia are doing with the help of PBH, NIPT. They are making an algorithm. They have validated their results, and non-invasive thing can be done. So from prenatal diagnosis, people are moved towards pre-implantation genetic diagnosis also, in which where there are precious babies, in vitro fertilization is done before implantation. Diagnosis of presence of these molecular markers can be done, and birth of a thalassemia major babies can be avoided. So we move towards more benign hematological disorder, that is thrombosis and hemostasis. Thrombophilia has been one area where clinicians are often having faced confusion that which test is to be done on which patient at what time. It's the confusion. So thrombophilia is an abnormality of hemostatic system which places an individual at increased risk of venous and or arterial thrombosis. They need to be treated with anticoagulants, and they always have a risk of recurrence. So we need to test them for some inherited thrombophilic markers. Inherited thrombophilia are like antithrombin deficiency, protein C, protein S deficiency, factor V Leiden gene mutation, and prothrombin gene mutation. Out of these, most frequently requested molecular test is for factor V Leiden and prothrombin gene mutation, which are commonly done with the melting curve analysis based methods. In factor V Leiden, what happens? There are cleavage sites we can see on the factor V heavy chain, and because of this point mutation, one cleavage site is lost. This cleavage site is lost, so activated protein C cannot act on activated factor V. Factor V, which is active, cannot be inhibited. So more and more factor V will remain in the circulation, which will predispose the case towards thrombosis. So this can be done with the help of molecular testing. In coagulation laboratory, we can do activated protein C resistance, but that is not very sensitive, because some other causes can also be responsible for this APCR. And further, there are many pre-analytical variables which can affect APCR. So factor V Leiden gene mutation is generally found in heterozygous or homozygous state, and it increases the risk of recurrence as well as the risk of occurrence of thrombophobia, thrombosis. This test was done earlier. Nowadays, it is not routinely prescribed. That is methylene tetrahydrofolate reductase assay, because there has been lack of association with the risk of venous thromboembolism. So not only we are increasing the menu, we are also decreasing at times if there is not suitable or good evidence. We move to hemophilia, hemophilia A, hemophilia B. These are X-linked recessive disorders. And after von Willebrand disease, these are the one of the most common bleeding disorders. Theme of World Hemophilia Day 2022 was access for all. So what we can do, again, we can do with the help of molecular testing, carrier state determination, prenatal diagnosis. We can predict cases who will develop inhibitor in the course of their treatment, and we can also predict responsiveness to immune tolerance induction in cases of hemophilia who are on treatment. I'm showing you one picture from 1970s, 1973, when first carrier detection technique was identified. So molecular testings have helped a lot. Not so commonly suspected in the past. Nowadays, it's much in discussion. Hemophagocytic lymphohistiocytosis. We look at these laboratory criteria. We look at 5 out of 8 criteria. We make a diagnosis of HLH, but we most of the time forget that there is one more thing, that is a molecular diagnosis consistent with HLH, except for some centers or in research settings. Most of the centers, we are not doing these molecular assays, but these are very important. They can be done, and HLH can also be typed. It can be identified that there are familial HLH, and genetic counseling may be required in those families where a case of familial HLH has been identified. If we cannot do all molecular testings, we can do some immunophenotyping assays, and accordingly, we can do testing of selected genetic markers. Next, autoimmune lymphoproliferative syndrome, again, a less commonly discussed entity. There is lymphoproliferation, and they are prone to develop neoplasms, lymphoid neoplasms. Again, to make a definitive diagnosis, we require mutation detection, somatic or germline pathogenic mutation, fast ligand. Why this is important? Because this was the one of the first well-characterized human genetic disease of apoptosis. We generally do not discuss subtypes of ELFs. Why? Because we require molecular diagnosis, whether the case is having fast mutation or other these mutations which are shown in the picture. We move again to one more benign disease, that is Fanconi anemia. We know there is bone marrow failure. There are many physical characteristics. Patients have of chromosomal breakage. We can identify it with the help of stress cytogenetics. But if we want to do molecular testing, there are a number of genes, and with the help of next generation sequencing, we can do. We need to identify and we need to acknowledge the fact that with the earlier available molecular techniques, we may not be able to we cannot uh, test one gene, then other gene, other gene. In present technique, that is NGS, it is helping us looking at all these molecular markers in one go, and this is of the technique. We move to next, why we are doing molecular diagnostics, although we have already seen how important it is for diagnosis, prognosis, prediction of therapy, but still we would like to learn this with the journey of few diseases like chronic myeloid leukemia. You know that the World CML Day is celebrated on 22nd of September, and the effort is to see that we all are together in fight of CML patients against this malignancy. Again, going back to basics, myeloproliferative neoplasms, these are clonal hematopoietic stem cell disorders and characterized by proliferation of one or more of myeloid lineage cells. Then these are associated with clonal abnormalities which encode cytoplasmic or receptor tyrosine kinase. Was described back in 1845, 1950, for more than 100 years. Recognition of CML relied on peripheral blood or bone marrow morphology as well as clinical examination. This was in 1960s when Nowell and Hungerford identified Philadelphia chromosome in the city of Philadelphia. This was the first, it is important thing that this was the first chromosomal abnormality identified in any malignancy, and identification of this Philadelphia chromosome and monitoring with the help of looking at this Philadelphia chromosome stayed the mainstay for next 3 decades. People were relying on, again, peripheral smear, lab score. In later, this Janet Robley, who received prestigious presidential award of USA, she identified this Philadelphia chromosome is the result of translocation between chromosome number 9 and chromosome number 22. And later it was identified that it leads to formation of chimeric fusion transcript, that is BCR-ABL1, and PCR assays were developed later on for identification of this. This BCR-ABL1 gives increases the propensity for proliferation, resistance to apoptosis, genetic instability, and when these molecular understanding were identified, targeted drugs were developed like imatinib, and it was so important that it found a place on front page of Time in May 2001. FISH was developed for fluorescent in situ hybridization method for identification of BCR-ABL1 fusion transcript. But now what we are doing commonly is qualitative and quantitative real-time reverse transcriptase PCR. Why? Because this is very, very sensitive, much more than conventional cytogenetics or FISH studies, and we can use very wider type of specimens, and it can detect many cryptic translocations also. With the help of quantitative PCR, we can see how level of BCR ABL1 fusion transcript decreases in peripheral blood of patient, and we can presume that how leukemic cells are also decreasing in the body of patient. So we look at this scale and we try to we have tried milestones. We have made milestones like at 3 months, less than 10% of load should be there. That is like near cytogenetic response. And at the end of 12 months, it should be less than 0.1%. That is called, we can see in this major molecular response. And on scale, we can see this is 3 log reduction. So commonly we use the term there is 3 log reduction at the end of 1 year. Anytime after, it should maintain on this. And those patients who are eligible for treatment-free remission study, BCR-ABL level should be less than 0.04, that is MR4 in these cases. Based on these testings, clinicians decide, they look at the responses of these milestones, they keep patients in green, yellow, or red zones. They look at the, if they find that the patient is going into yellow zone, the BCR-ABL level is not decreasing as expected, they evaluate patient compliance, look at drug interactions, they do ask for mutation studies. What mutation studies? We have seen that the BCR-ABL1 is one tyrosine kinase, and substrates are activated. The activation of these substrates, but imatinib goes and binds into ATP binding domain, and it inhibits substrate interaction with BCR-ABL. When this area where imatinib is binding, this develops mutation. This leads to resistance to mutation, resistance to imatinib, and these mutations can also be identified with molecular techniques. So when a person is not attaining molecular milestones or response milestones, mutation analysis are done, and there are n number of mutations, out of which many are having intermediate sensitivity to these tyrosine kinase inhibitors, and many of these mutations are resistant, like T315I, which is resistant to all three these tyrosine kinase inhibitors, imatinib, nilotinib, dasatinib. In these cases, we may have to go for different tyrosine kinase inhibitors, or patients may have to go for hematopoietic stem cell transplantation if some mutations are found which are resistant to all TKIs. Change in goal is also happening in CML therapy. Patients who are maintaining deep molecular response for uh, pre-decided time, they are taken in for treatment-free remission. Patients are kept off imatinib, and then they are monitored with the help of molecular testing. And this is very important for a disease which was 40 years back, it was lethal, and only cure was hematopoietic stem cell transplantation. Because of understanding of molecular pathogenesis, molecular testings, and development of target therapy for this molecular abnormality, we could have this day when we are talking about treatment-free remission. So next we move the track, we move towards acute leukemia, very tricky. There are many classifications. Why do we classify? Classification is language of medicine. We require it for describing, defining, and naming diseases before we go and treat, diagnose, and study diseases. We can define acute leukemia by clinical features also. If the patient is having lymphadenopathy, hepatosplenomegaly, possibly acute lymphoblastic leukemia, more of bleeding manifestation, possibly AML. But morphology played a big role. FAB classification. Still, we read FAB classification because it was the base or backbone of AML classifications. We moved towards 2001, 8, 16 WHO classification, and the emphasis of molecular marker has been increasing. Number of blasts are decreasing for diagnosing, whereas number of molecular abnormalities are increasing. And in current update of WHO classification, what we can find that there are many genetic abnormalities, disease-defining genetic abnormalities are there. And if we look at acute myeloid leukemia, myelodysplasia related, there are also disease-defining somatic mutations. So if we do not use molecular techniques, we will be stopping ourselves till acute myeloid leukemia. Flow cytometric immunophenotyping was very attractive for many years. We are diagnosing still only acute myeloid leukemia with flow cytometry. What we require now is molecular testings. So why? Because we have found that it's a heterogeneous disease, and we can find that in acute myeloid leukemia, there is presence of n number of molecular abnormalities. In this picture, what we can see that FLT3 is one of the most common molecular abnormality. Many mutations are there. Cytogenetic and molecular patterns are mutually exclusive. So we can classify AML prognostically and biologically two different subsets. If we look again at prognostic stratification, what we see that there are various subgroups based on these molecular abnormalities. And these molecular abnormalities are important because there are novel drugs in pipeline which we can use if we identify these molecular abnormalities, like it was used in acute promyelocytic leukemia, where PML-RAR alpha fusion gene was target for ATRA. And again, in that APML also, now what we are discussing is molecular remission. With the help of PCR, we are looking at PML, RAR, alpha fusion transcript level, and we are making new goals. Myeloid differentiation factor 88, universal presence is found in Waldenstrom macroglobulinemia. Not only it's a diagnostic marker, but it also helps in prognosis of IgM MGUS cases where higher load can indicate poor prognosis and faster progression towards Waldenstrom macroglobulinemia. Hairy cell leukemia, we have been using flow cytometry, but the BRAF V600E mutation is a disease-defining mutation, and there is a targeted therapy in the form of vemurafenib, and this is useful in relapsed refractory HCL cases. So again, I ask why. Two slides. Next slide is having two disturbing image. Caution is advised. We travel a lot, but we are never afraid of such features. These figures. Why? Because we know airline authorities have very good quality control measures. If we look at 2021 data, only there were 7 fatal crashes out of 2.57 crore airline flights. So one in 9.9 lakh flights, because they are doing their job perfectly. We have seen in COVID-19, there has been surge of molecular laboratories across India. And if we look at this picture from ICMR website, there are 2,895 laboratories. When there was a need, we developed molecular laboratories. But if I go back towards hematology side, come to reality, in Rajasthan, across medical colleges, only 2 medical colleges, one in private, one in government, is giving services for BCR-ABL1 detection. So this is reality. Yes, we have a long way to go. And before I end, I would say hematology has been the discipline at the forefront of using molecular methods to understand disease etiology, diagnose disease, stratify patients based on prognosis and response to therapy. And recent advances in sequencing has offered new opportunities in research as well as in clinical practice. Conventional diagnostic methods are important, but we require more and more molecular testings, and NGS has helped a lot. This is my institution and my city, and this is my department at AIIMS Jodhpur. Thank you.
A very wonderful presentation, sir. You have beautifully simplified the things, and I hope the audience has enjoyed your presentation and gained the knowledge. Now I request Dr. Dipanjan to share some clinical experience.
Firstly, thank you, Dr. Abhishek, for the wonderful talk. In about 40 to 45 minutes, we have covered almost full details of molecular diagnostics in hematology, starting from benign diseases, malignant diseases, and very beautifully you have touched upon the subject in very short period of time. Uh, So regarding clinical experience, yes, I completely agree with you. Nowadays, we cannot practice hematology without the backup support of a molecular hematology lab. And it is quintessential to practice hematology. For example, just like you're mentioning BCR ABL. So nowadays, even for whenever we are diagnosing any case of acute leukemia, it is mandatory for us to send, for example, acute myeloid leukemia, we always try to send next generation sequencing, because we have got targeted therapies against each of these particular genetic mutations. For example, for FLT3 mutated patients, it's absolutely essential that we use midostaurin or any other targeted FLT3 molecules. For CML patients, again, targeted therapy has been the cornerstone for last about 2 to 3 decades now. So definitely molecular diagnostics and in hematology is the backbone of hematology practice, and more and more it will be playing role in the coming years to come. I'd like to thank the organizers for giving me this opportunity.
Thank you so much, sir. Dr. Pulkit Rastogi, request him to give your valuable opinion.
Yeah.
Uh,
Am I audible?
yes, sir, you're
Yeah,
audible.
yeah. Thank you, organizers, for giving this opportunity to chair the session. And it was a fantastic talk by Dr. Abhishek Purohit. He has touched all the domains of hematology, be it benign, malignant, and malignant. He has touched acute leukemia, myeloproliferative neoplasms, and lastly, the lymphomas, and also the role of MRD testing in the molecular hematology. And so, yeah, so to start with, I would like to say that whenever you are planning molecular testing in your lab, so you should start with the basics. So firstly, initially, don't go directly jump for understanding the NGS or like that. You should start with the basic ones, the how a basic setup of PCR is there, and then you switch to the reverse transcriptase and then the real-time PCR, and then slowly, gradually, you will get into the next generation sequencing, which is now becoming essential for managing the patients of malignancies in hematology. So with this, I think we can take a few questions from the audience if they would like to ask Dr. Purohit.
Question answer round in the end. Sir, we have question answer round at the end of the session, if
Okay,
possible.
okay, fine. So I have okay, fine. Then we can take up
Sir,
later.
if you,
Yeah,
yes, sir, you can ask, sir. Sir, if you have.
yeah. Yeah, so I would just like to ask sir's experience on initial setup of the molecular testing in his lab, any constraints that he faced, or because in India we do have a lot of constraints, especially in the government setup, and yeah, initially for the QC and everything. So those aspects needs to be keep in mind while you set up a molecular test in your lab.
So yes, I agree with you, Dr. Pulkit. It is not easy to start with these things in government setups. Even in private hospital, earlier I was working in a cancer hospital for 1 year. Yeah, by the end of 1 year, we could got approval. And in my institution, I have been working here for last 6.5 years. Slowly and slowly, things are developing. And now we are in a position that we are running flow cytometric immunophenotyping, and possibly before the end of this financial year, we will be starting with BCR-ABL1 and JAK2 mutation, these two. So I
Yes.
will not go into details, but it's not easy. In just one sentence, I would say.
Definitely. So once you have established everything, then it becomes a very smooth curve. And then, yeah, these are the important tests, at least the BCR ABL testing and the JAK2 testing, because you get a lot of patients which are amenable to treatment. They take the therapy and it is affordable for them. So these are the basic tests. And for maybe for the referral centers, one has to start for the thalassemia testing, which are routinely screen for antenatal for the women who come for the antenatal screening so as to prevent this dangerous disease.
Yes, as a
Yeah,
part of
with this,
Nidan Kendra, that is a DBT funded project, we are doing thalassemia testing, but that is mainly in the, not for routine. A few cases of prenatal testing, genetic testing have also been tried here, but still things are developing.
yeah. So one has to be very positive for this and definitely should take further. So thank you so much, sir, for the wonderful talk. And with this, I give over to the Dr. Gurvinder to carry the further proceedings. Thank you.
Thank you, sir. Thank you, Abhishek, sir, for your nice presentation. We really enjoyed your presentation, sir. You have simplified the topic, although we know the molecular pathology is very complex pathology. And now I will thank the chairperson also for joining us. Thank you all. Now, our second session is on the very interesting topic on the role of molecular pathology in head neck tumors. To talk on that, we have Dr. Aanchal Kakkar ma'am, who is Associate Professor in the Department of Pathology, AIIMS, New Delhi. She has keen interest in head neck pathology since 2017. She has more than 150 publications, 15 book chapters, and she is one of the contributing author in 5th edition of WHO classification. It's my pleasure that I got opportunity to introduce ma'am. This session will be chaired by Dr. Rajiv Kaushal and Dr. Darwin Kaushal sir. Dr. Rajiv Kaushal, currently he is professor in TMH Mumbai. He received his medical degree from Grant Medical College and post-graduation from TMH Mumbai and PGI Chandigarh, and came back to TMH back as faculty in 2012. He has a special interest in thoracic, gastrointestinal oncopathology, molecular pathology, and digital pathology. He has multiple national and international publications. Our second chairperson is Dr. Darwin Kaushal, who is MS DNB, FACS, ex-associate professor from AIIMS Jodhpur, currently working as associate professor in AIIMS Bilaspur. He is quiz master in more than 6 national conferences till date. He has been authored many national and international papers, many book chapters, and PG entrance books. Area of interest is head and neck and skull-based surgery and pediatric otolaryngology. I welcome all of you, sir, over the same platform, and I request Dr. Aanchal ma'am to take over this session. Ma'am, you are not audible. Ma'am, please unmute yourself.
Is that better?
Yeah. Yes, ma'am.
Good morning, everyone, and I'd like to thank the Department of Pathology at AIIMS Bilaspur for including me on this very relevant CME on molecular pathology. And so I'm going to jump right into the role of molecular pathology in head and neck cancer. In recent years, there has been a paradigm shift in the classification of head and neck neoplasms due to the numerous advances in molecular pathology, mostly owing to the decreased cost and widespread use of whole genome, whole exome, and transcriptome sequencing techniques, which have allowed better classification of previously heterogeneous categories of tumors, and it has also led to the discovery of novel tumor types. The new 5th edition of the WHO classification of head and neck tumors takes all of these advances into consideration and identifies several new diagnostic entities and includes molecular attributes in the definition and the diagnostic criteria of many entities. As pathologists, it is imperative that we are conversant in molecular techniques and include them into our routine reporting as is required for precise diagnosis and patient management. The CAP protocols also have a head and neck biomarker reporting template, which lists out the number of molecular tests that are required in head and neck cancers. And these include human papillomavirus testing and the various methods, Epstein-Barr virus testing, diagnosis of nut midline carcinoma, salivary gland carcinoma, sinonasal malignancies, and paraganglioma. So I'm going to cover all of these in stepwise. Let's begin with HPV testing at head and neck cancers. Human papillomavirus has been increasingly recognized as a key etiological driver in carcinomas of the head and neck, and HPV-associated oropharyngeal carcinoma is the prototypic manifestation of head and neck HPV-related neoplasia. It was recognized as a distinct entity by the 4th edition of the WHO classification and the 8th edition of the AJCC staging system in 2017. The reason for this is that since the late 1980s, there was a gradual decline in the incidence of head and neck cancers due to a decrease in the primary risk factors like smoking and alcohol consumption. However, there was a dramatic rise in the incidence of oropharyngeal cancer due to an exponential increase in HPV-associated cancers and a decrease in the incidence of HPV-negative cancers. This was mostly reported from the developing countries. Clinically and histopathologically, HPV-associated oropharyngeal squamous cell carcinoma is a unique subset of squamous cell carcinoma, which is why it was separated from oral squamous cell carcinoma. It has distinctive demographic profiles being seen in younger patients with higher socioeconomic status and different clinical presentation with small primary tumors and large lymph node metastasis. The morphological features are also unique as it is usually a non-keratinizing squamous cell carcinoma, but most relevant is that these tumors are associated with improved clinical outcomes. The oropharynx is seen here in this diagram is characterized by the presence of tonsillar tissue with crypts which are lined by highly specialized reticulated epithelium which lacks a basement membrane and enables lymphocyte trafficking into the epithelium, providing a more permissive environment for HPV infection and promoting HPV-driven tumorigenesis. A similar phenomenon is seen in the nasopharynx and EBV-associated squamous cell carcinomas. On histology, oropharyngeal squamous cell carcinomas are usually non-keratinizing tumors that infiltrate beneath the surface epithelium without associated surface dysplasia. You see nests and lobules with smooth edges, with pushing borders and central necrosis. Tumor cells have high nuclear to cytoplasmic ratios, oval to spindle hyperchromatic nuclei, syncytial cytoplasm, and they lack significant cytoplasmic keratinization. In situ lesions are not recognized. All tumors are considered invasive and grading is not applicable to these tumors. A number of subtypes of squamous cell carcinoma are known to be associated with HPV, such as the basaloid squamous cell carcinoma, papillary squamous cell carcinoma, lymphoepithelial carcinoma, adenosquamous carcinoma, ciliated adenosquamous carcinoma, and even small cell carcinoma. However, just histology alone cannot help us decide whether a tumor is HPV associated or not, which is why we require HPV testing. HPV testing is not only required for oropharyngeal squamous cell carcinoma at primary or metastatic sites, but also in metastatic squamous cell carcinoma of an unknown primary site when present in level 2 and 3 cervical lymph nodes. It is required for diagnosis of sinonasal HPV-associated squamous cell carcinoma, HPV-related multiphenotypic sinonasal carcinoma, the recently identified HPV-associated oral dysplasia, and ocular adnexal carcinomas as well. The CAP recommendations published in 2018 state that all newly diagnosed oropharyngeal squamous cell carcinoma should undergo high-risk HPV testing, regardless of the histological type, keratinizing or non-keratinizing, either on the primary or on metastasis. And on tissue specimens, it suggests that the surrogate marker P16 immunohistochemistry is appropriate. However, it states that additional HPV-specific testing may be performed at the discretion of the pathologist or the treating clinician or in context of a clinical trial, but it does not specify further which method should be used. Next, metastasis from unknown primaries also. P16 can be used in level 2 and 3 nodes. However, additional high-risk HPV testing should be performed on P16 positive tumors outside of level 2 and 3 and for those tumors with keratinizing morphology. The recent WHO classification, which is about to be published soon, includes high-risk HPV testing in the essential criteria for diagnosis as determined by surrogate marker P16 immunohistochemistry or by P16 immunohistochemistry plus HPV-specific testing. But again, it doesn't state when do we require HPV-specific testing. So let's look into what we mean by detection of transcriptionally active HPV. We know that the viral particles contain the viral DNA genome, which enters the host cells and gets integrated where it undergoes transcription to form the E6, E7 mRNA by the active virus, which then gets translated into E6, E7 oncoproteins, which are responsible for inducing carcinogenesis. The expression of E6, E7 mRNA indicates oncogenic activity of high-risk HPV and is considered a driver of carcinogenesis. However, detection of DNA alone indicates the mere presence of HPV within the cell and not of integration. And this can also detect passenger or bystander HPV, which might not be oncogenic. So the initial test for detection of HPV was PCR amplification of the HPV genome, which was in use for more than 30 years. It was a highly sensitive method with high specificity in fresh tissue, but not on FFPE tissue. The advantage of DNA-based tests are that you can identify the specific HPV genotype. But the disadvantages are that the DNA yield from FFPE specimens is influenced by formalin concentration, duration of fixation, and we all know that formalin induces fragmentation of nucleic acids, and thus this method is associated with reduced sensitivity. Further, contamination is frequent. The method requires technical expertise that pathologists are not familiar with, and most importantly, it also detects passenger HPV DNA within cells, which leads to low specificity. HPV E6, E7 mRNA detection by real-time PCR was previously considered the gold standard for diagnosis of high-risk HPV. However, this is optimized for fresh or frozen tissue samples and has low accuracy on FFPE tissue, as RNA is more fragile than DNA and undergoes greater destruction and fragmentation, making this a very technically demanding procedure which is not useful for routine screening. This led to the advent of in situ hybridization techniques. In situ literally means on the tissue section, and it is based on hybridization of probes against HPV-specific DNA sequences. This technique is relatively inexpensive and is pathologist friendly. We like it because we read it by conventional light microscopy. The sensitivity and specificity are dependent on the type of probe used, and the technique is highly dependent on quality control procedures and the experience of the lab. False negativity has been reported in up to 45% of cases, particularly when the number of copies of HPV within the cell are lower than 100. P16 immunohistochemistry thus emerged as a reliable surrogate marker for transcriptionally active HPV, as the E7 oncoprotein signaling induces overexpression of cellular P16-INK4A protein. This is a very cost-effective and practical technique which is rapid and reproducible, easy to interpret, with high inter-observer agreement. And the sensitivity and specificity have been reported to be very high, up to 100% and up to 85% respectively. Most importantly, it has been shown to be an independent predictor of survival. The NCCN guidelines for management of head and neck cancer state that there are currently no diagnostic tests with regulatory approval, but it recommends HPV testing by P16. However, it also states that due to variations in sensitivity and specificity of testing options, multiple methods may be combined for HPV detection. When do we need multiple methods? It does not mention that. Let's look at some clinical scenarios. This is a 65-year-old male with a level 2 cervical lymph node biopsy, which showed a P16 positive squamous cell carcinoma of an unknown primary site. The PET-CT could not identify a primary site, so the patient underwent a transoral ultrasound surgical excision, assisted bilateral tonsillectomy, and base of tongue mucosectomy. And here you can see that the base of tongue mucosectomy shows a less than 1 millimeter thick atypical squamous proliferation, which in the sections for immunohistochemistry, the tumor was depleted, but few tumor cells that were present were immunopositive for P16. So P16 does help us in identifying the primary site in the oropharynx and is therefore very useful. However, there are few caveats that P16 is a reliable HPV surrogate only in oropharyngeal carcinomas, and it has low specificity for HPV at other sites, as metastatic non-keratinizing squamous cell carcinomas from oral cavity, larynx, and skin, and basaloid squamous cell carcinomas may also show P16 positivity. While using the P16, the cutoff for interpreting positive is important, and 70% of cells with nuclear and cytoplasmic staining should be considered positive. The E6H4 clone, which is recommended, is expensive and costs about 5 times that of other clones. And if we're using another clone, we need to validate it against the E6H4 prior to using it for taking treatment decisions. E16 immunohistochemistry also does not inform on HPV genotypes like DNA PCR does, and some HPV types have been predicted to have worse outcome as compared to HPV 16, which is the most common. Further, most importantly, it has poor sensitivity in low prevalence populations. So is our country a low prevalence or a high prevalence population? That would impact how we interpret P16 positivity. So if you look at this nice review by Nair et al., where they summarized the prevalence of HPV in head and neck cancers across India, there is a single study by Bell et al., which looks at oropharyngeal carcinomas only, and they identified a prevalence of 22% by DNA PCR. More recent studies using P16 immunohistochemistry have shown that about 13% of cases were positive for P16, and they showed that it had an independent impact on outcome, indicating that yes, it is a prognostic marker. However, other studies have shown that while there is a low prevalence of P16 positivity as well as mRNA-ish, there is poor concordance between HPV testing methods at low prevalence rates. That means in our scenario, P16 does not correlate well with HPV-specific methods, and therefore it's not a good surrogate for high-risk HPV and cannot be used as a standalone test when we are considering de-escalation of therapy for these patients. Let's look at this lymph node metastasis, which clearly shows a non-keratinizing squamous cell carcinoma with trabecular architecture, which is diffusely positive for P16. This patient had a primary in the eyelid, thus P16 is not specific for an oropharyngeal primary. Here we have a case of a base of tongue adenosquamous carcinoma with squamous as well as glandular architecture. These tumors are known to be positive for HPV, and here it is P16 positive. But we also have another tumor in the base of tongue which shows a squamous and granular proliferation. This is a mucoepidermoid carcinoma, which is again diffusely P16 positive. Thus, P16 is not specific for HR-HPV, and it can be overexpressed by other mechanisms as well. This is why the popularity of high-risk HPV mRNA-ish has risen in the last decade. It has high sensitivity and specificity approaching 100%, and the small size of the probes used enables hybridization to even degraded mRNA in FFPE tissue samples. The results are read on a light microscope, as you can see here, similar to immunohistochemistry, and it's therefore a pathologist-friendly technique. And most importantly, is biologically relevant. The signals are located within the nucleus, indicating transcriptionally active infection. It detects E6, E7 transcripts from various HPV genotypes, and automated assays are available which have high concordance with manual assays. And however, the disadvantage is that it is expensive as compared to immunohistochemistry, and it cannot specify which high-risk HPV type is present. Somebody speaking in the background, can they please mute themselves? Thank you. So this is now considered the gold standard high-risk HPV assay for FFPE tissue samples. And let's see its utility. So here we have two sinonasal tumors, case 1 and 2, both of which have tubular equilibrium architecture with some basaloid matrix which is present between the tumor cells. Both of them look like adenoid cystic carcinoma. Both of them are diffusely immunopositive for P16. However, case 1 shows a break apart of the MYB gene as shown by one split signal over here. However, the second case does not show rearrangement of the MYB gene. You have two retained fused signals which are yellow in color. Why is this? The second case shows a biphasic immunophenotype with cytokeratin EMA and CD117 positivity in the luminal cells, while smooth muscle actin and P40 stain the abluminal cells, just the same as adenoid cystic carcinoma. However, high-risk HPV mRNA-ish shows the presence of HPV, indicating that this case is HPV-related multiphenotypic sinonasal carcinoma. This tumor is a new distinct entity described in sinonasal region, which is an HPV-positive carcinoma with histopath appearance similar to that of adenoid cystic carcinoma, with multiple lineages of differentiation. However, it shows dysplasia in the overlying epithelium, suggesting an origin from surface epithelium along with the submucosal senomucinous glands. It has a distinct molecular signature, the absence of MYB gene fusions, and presence of transcriptionally active high-risk HPV. Importantly, it has a more indolent clinical course as compared to adenoid cystic carcinoma, which is why it should be distinguished from it. However, adenoid cystic carcinomas can show diffuse P16 positivity as we saw. Therefore, HPV-specific molecular test is required to distinguish between these two tumors. Looks like we have another sinonasal tumor here. This is a 45-year male with a non-keratinizing squamous cell carcinoma that is diffusely immunopositive for P16. However, when we see the mRNA-ish, it is negative for a high-risk HPV, while the positive control ubiquitin C shows that the procedure has worked. Cytosequencing identified EGFR exon 20 mutation in this case, indicating that this is an EGFR mutant non-keratinizing squamous cell carcinoma, which however showed P16 immunopositivity. Which is why we need mRNA-ish in such situations. To summarize, the HPV status informs clinical management and treatment decisions for patients with head and neck cancers. HPV-specific molecular tests aid in differential diagnosis of histologically similar cancers which may show P16 positivity, and it helps determine patient eligibility for clinical trials investigating new treatment modalities and regimens. HPV positivity in metastatic squamous cell carcinoma of unknown primary to cervical lymph node strongly points to the oropharynx as the site of origin. It is also important for counseling and patient education purposes regarding the etiology of their cancers. Several techniques are available for detection of high-risk HPV and FFP in tissue and cytological material. However, the guidelines from Western high-prevalence populations cannot be readily applied to Indian patients. While P16 immunohistochemistry is the most commonly used technique, it has high sensitivity but lacks specificity, and mRNA-ish is considered the gold standard technique for FFPE tissue samples. An algorithmic approach with P16 followed by reflex mRNA-ish in positive cases appears to be cost-effective and is ideal for routine clinical practice. Since we started off with a few sinonasal tumors, let's go into the rest of them. We talked about EGFR mutations in sinonasal squamous tumors. A few recent studies have reported these mutations in sinonasal inverted papillomas as well as squamous cell carcinomas, and exon 20 mutations have been found to be most common. In addition, paired samples from papillomas and squamous cell carcinomas in the same patient have had the same mutation, which supports the role of inverted papillomas as a precursor for squamous cell carcinomas. EGFR mutations are mutually exclusive from high-risk HPV, and it has been found that EGFR wild-type inverted papillomas develop squamous cell carcinoma more frequently. In addition, EGFR mutated squamous cell carcinomas have differences in survival as opposed to EGFR wild-type carcinomas. We have found that majority of inverted papillomas show these mutations, and all squamous cell carcinomas arising in the background of papillomas were positive for EGFR mutations. However, we identified a high proportion of EGFR mutations in de novo squamous cell carcinomas as well, much higher than reported in literature, which may be attributed to the low prevalence of HPV in our population. Detection of EGFR mutation helps us in determining which inverted papilloma patients have higher likelihood of progressing to squamous cell carcinoma, and also, more importantly, in identifying patients who are likely to respond to EGFR inhibitors in recurrent and metastatic settings. Importantly, in tumors of the sinonasal region, P16 immunopositivity lacks specificity for high-risk HPV, as it was found to be positive in EGFR mutant and mRNA-ish negative cases. Thus, we require HPV-specific molecular tests. Let's move on to this case of a 10-year-old female with a pale fiber mass in the nasal cavity. She had been operated previously with histopath diagnosis of basal cell carcinoma and inverted papilloma from 2 different labs. You can see an undifferentiated appearing tumor with large areas of necrosis. These are the tumor cells which appear basaloid with scant cytoplasm. On high magnification, you can appreciate that there is some peripheral palisading or nuclei, as well as foci of squamous differentiation, and the tumor cells were immunopositive for P40. So when we have undifferentiated basaloid tumor cells with abrupt squamous differentiation, the diagnoses that come to mind are nut carcinoma and adamantinoma like Ewing sarcoma, and sure enough, this case was positive for nut, making it a nut carcinoma. This is an epithelial malignancy with a monotonous appearance occurring in head and neck sites, and it is characterized by the rearrangement of the NUT-M1 gene, with the most frequent fusion partners being BRD4 and BRD3. The WHO includes identification of the rearrangement as an essential criteria for diagnosis. It can be detected by FISH, reverse transcriptase PCR, and targeted next-gen sequencing. However, NUT immunohistochemistry is a reliable surrogate as it is expressed normally only in the testis, and it has 100% specificity when we take a cutoff of 50% of cells showing positivity. These tumors have uniformly poor prognosis, which is why their diagnosis is imperative. You can see that the differential diagnosis is very wide, and that is why NUT immunohistochemistry should be performed upfront in all poorly differentiated carcinomas of the head and neck, irrespective of whether foci of squamous differentiation are seen or not, as they might be absent. Next, we have a 29-year-old male with nasal obstruction and epistaxis. You can see a subepithelial tumor, again composed of basaloid cells. which appear monotonous on high magnification with uniform appearing nuclei. However, there are many mitotic figures that are seen over here. This tumor was also positive for CK and P40, however, NUT was negative. So what is the diagnosis here? This tumor was found to be positive for CD99 or MYC2 as well as NKX2.2, and EWSR1 FISH showed a break apart of the EWSR1 signal, indicating that this is a sinonasal adamantinoma like Ewing sarcoma. This is a rare histological subtype of Ewing sarcoma characterized by complex epithelial differentiation, diffuse expression of high molecular weight keratins P63 and P40, which are squamous markers, and it harbors the pathognomonic translocation seen in Ewing sarcoma, that is the EWSR1 Fly1 gene rearrangement. Originally described in the extremities and thorax, it has now been increasingly reported in the head and neck at various sites. The diagnostic genetic alteration can be detected by break-apart FISH or reverse transcriptase PCR and is a desirable criteria for diagnosis in the upcoming WHO classification. The clues to identifying this tumor are the presence of basaloid cells with monotonous cytology and strikingly isomorphic nuclei in the presence of high-grade features like necrosis and brisk mitosis. Features like abrupt squamous differentiation, peripheral palisading, and rosette formation are not always present. So that is why we need to include the Ewing sarcoma marker CD99 and NKX2.2 in our panel for any undifferentiated or basaloid appearing tumor. In the sinonasal tract, NUT carcinoma, basaloid squamous cell carcinoma, neuroendocrine carcinoma, high-grade olfactory neuroblastoma, Weissenhoff deficient carcinomas, and SNUC may all have overlapping histomorphological features, which is why genetic confirmation has been recommended by the WHO 2022 given the overlap with the differential diagnosis. Next, we have a 70-year-old male with a sinonasal mass, which is composed of tumor cells in large nests and islands. You can see that the cells are quite monomorphic appearing. They have moderate amount of cytoplasm and large nuclei with fine chromatin, some of them with conspicuous nucleoli. On immunohistochemistry, these tumor cells are positive for cytokeratin and show very faint, patchy positivity for neuroendocrine markers, chromogranin, synaptophysin, and INSM1. However, the Ki67 labeling index is very high, and these tumors show retained expression of INI1. However, there is loss of SMARCA4 or BRG1 protein, which is, you can see that it is retained in the endothelial and inflammatory cells where the tumor cells are negative. This is a case of SMARCA4 deficient sinonasal carcinoma. The Weissenhoff complex is a multi-unit chromatin remodeling complex of more than 20 genes, which performs fundamental roles in regulation of gene expression, cell lineage specification, and regulates nucleosome positioning throughout the human genome. This complex collectively possesses tumor suppressor properties, and that is why inactivating loss of function mutations, deletions, and rarely epigenetic silencing lead to loss of immunoexpression of the proteins INI1 and BRG1. These alterations in these genes are seen in nearly 25% of all cancers, which is really high, with only P53 being higher. And that is why this is being evaluated extensively for targeted therapies. SMARCA4 deficient sinonasal carcinoma has recently been identified in poorly undifferentiated sinonasal tumors with morphological features of neuroendocrine carcinoma, SNUC, and teratocarcinosarcoma, which is why it has now been included in the new WHO as a Weissenhoff complex deficient sinonasal carcinoma, which includes both SMARCB1 and SMARCA4. These are both poorly to undifferentiated epithelial malignancies defined by loss of one complex subunit without histological features allowing classification into another specific entity. The histological features are heterogeneous, mostly consisting of undifferentiated large cells which stain diffusely with cytokeratin and show weak, patchy positivity for neuroendocrine markers and a negative for squamous markers and NUT. These tumors have aggressive clinical behavior, which is why we need to diagnose them upfront. And loss of SMARCA4 immunoexpression is the essential diagnostic criterion in the WHO, which is why BRG1 should be applied in the initial panel for diagnostic workup of all undifferentiated sinonasal malignancies. Next, we have a 25-year-old male. Can you please mute? Thank you.
Just mute yourself. Who is on? Whose speaker is on?
We have a 25-year-old male with a maxillary sinus lesion. You can see sheets of tumor cells which have scant cytoplasm at places, whereas in other areas they appear to have moderate amount of clear cytoplasm. The tumor cells do show the presence of empty vacuoles which are pushing the nucleus to the side, and at other places you can see the nuclei are large vesicular with prominent nucleoli. These tumor cells are diffusely positive for cytokeratin and P40 and show loss of INI1 immunoexpression. We have another case of a 20-year-old male with a recurrent maxillary mass, which is showing a tumor composed of sheets of cells with bone destruction. This tumor, unlike the previous one, does not show basaloid cells but appears to have cells with abundant pink cytoplasm, including those with bright pink cytoplasm and an eccentrically located nucleus resembling rhabdoid cells. This tumor was also interestingly negative for P40 and showed loss of INI1. These two cases highlight the differences in morphology and the immunohistochemical profile of SMART-B1 deficient sinonasal carcinomas. These are aggressive tumors which usually present at advanced stage with bone destruction and periorbital infiltration. The driver genetic event in these tumors are inactivating alterations in SMART-B1, which can be demonstrated by loss of immunoexpression of INI1. Histologically, they may either be basaloid tumors or plasmacytoid rhabdoid tumors in a smaller proportion, and rarely they may have an adenocarcinoma-like morphology composed of oncocytoid plasmacytoid cells with abundant pink cytoplasm which form glands and also show yolk sac-like features. When should we suspect this tumor? When we see focal P63 or P40 positivity in a tumor which does not show overt squamous differentiation, or when we see focal neuroendocrine marker positivity without neuroendocrine morphology, or when we have negative myoepithelial markers in tumors which have a plasmacytoid appearance. Let's go on to the next case, which is that of a 42-year-old female with nasal obstruction and epistaxis. You can see a subepithelial tumor with entrapped epithelial invagination. The tumor is composed of spindle-shaped cells which have moderate amount of cytoplasm and bland appearing elongated ovoid nuclei. This tumor was immunopositive for smooth muscle actin as well as S100, indicating a dual neural and myogenic phenotype. Beta-catenin positivity was present and it was negative for STAT6. And this is a case of biphenotypic sinonasal sarcoma. However, there is no specific antibody which can confirm this diagnosis, as beta-catenin positivity is seen in other tumors which have similar morphologies. This is a rare low-grade mesenchymal neoplasm seen exclusively in the upper sinonasal tract, and it was previously diagnosed as fibrosarcoma, MPNST, and myxofibrosarcoma. It is characterized by a distinctive genetic signature, that is the PAX3 gene rearrangements, and sure enough, the present case showed the presence of PAX3 break-apart signal. And this is included as a desirable diagnostic criteria in the new WHO, and it can be identified by break-apart FISH. And however, next-gen sequencing would be required to identify the specific fusion partner if necessary. You can see the differential diagnosis is wide and there is considerable overlap in the immunohistochemical features, which is why molecular testing is necessary to make the diagnosis. To summarize, sinonasal neoplasms are a diverse group of tumors. Many of the genetically defined entities are associated with aggressive clinical behavior, making accurate diagnosis necessary. Surrogate immunohistochemical markers are available for most of them, facilitating diagnosis without having to go into more expensive molecular testing. However, a strong index of suspicion is necessary on the part of the pathologist to include them in the diagnostic workup of sinonasal tumors. Next, we move on to molecular testing in salivary gland tumors, which is probably more vast than sinonasal tumors because this is one of the most difficult areas of head and neck pathology, as these tumors encompass a broad histological spectrum with a diversity that is arguably unparalleled in comparison to other organs. In recent years, knowledge of genomic landscape of salivary gland tumors has increased, leading to identification of new entities as well as new subtypes of well-defined neoplasms. However, these often have overlapping histological and immunohistochemical features due to similar cells of origin, and there is also marked morphological heterogeneity within individual entities, leading to increasing requirement for molecular testing for confirmation of diagnosis. In addition, newer therapeutic targets are also being identified, necessitating molecular testing. So when we look at all the molecular alterations seen in salivary gland tumors, which have a diagnostic role, you can see in the ones which are in red are those which are included in the WHO definition of these entities, and green are the ones which are included in the desirable diagnostic criteria. The ones in blue, like the HRAS mutation and epithelial myoepithelial carcinoma, is only included in the section on diagnostic molecular pathology and aids in differential diagnosis. Let's look at one of the new entities that has been identified based on its molecular alteration, that's microsecretory adenocarcinoma. It's a low-grade salivary adenocarcinoma with distinctive morphology and the characteristic MEF2C SS18 fusion, which emerged from the group of tumors called adenocarcinoma NOS recently. This SS18 gene rearrangement can be demonstrated by FISH, next-gen sequencing, and reverse transcription PCR. Although it's an infiltrative tumor, none of these have shown recurrence or metastasis, which is why we need to identify them and distinguish from other morphologically similar tumors, which would be secretory carcinoma, adenoid cystic carcinoma, and polymorphous adenocarcinoma. These tumors are diffusely immunopositive for S100, SOX10, and P63, while P40 is negative, which is the exact immunoprofile of polymorphous adenocarcinoma. Looking at the differential diagnosis, while we can separate secretory carcinoma and adenoid cystic carcinoma from microsecretory carcinoma with immunohistochemical markers that are available, polymorphous adenocarcinoma can show similar morphology as well as has the exact immunohistochemical profile, necessitating the identification of the SS18 translocation. This is a diagrammatic representation of the same and Sanger sequencing of the PCR product showing the fusion product, and it can also be identified by SS18 break apart FISH, which is the exact same FISH probe that is used for diagnosis of synovial sarcoma as the same gene is involved. Coming on to new subtypes of old tumors, here we have sheets of oncocytic cells in an aspirate with a mucoid background as well as cells with vacuolated cytoplasm. On excision, this tumor showed what appears to be a Warthin tumor. However, on higher magnification, you can appreciate the presence of mucus cells lining some of the cystic glandular spaces, and Alshan blue positivity is seen within these tumor cells, confirming the presence of mucin. So is this a Warthin tumor with mucinous metaplasia, or is this a Warthin-like mucoepidermoid carcinoma, which is a new subtype of this tumor? We performed mammal 2 FISH, and you can see that there is no rearrangement, indicating that this is a Warthin tumor with mucinous metaplasia. As till date, all reported cases of Warthin-like mucoep carcinoma have shown mammal 2 rearrangements. Moving on from the new to the good old diagnostic dilemmas, we have here an infill tumor composed of irregular nests of tumor cells with what appears to be paleosinophilic cytoplasm. They appear to be like intermediate cells. In other areas, you have cells with clear cytoplasm. Is this a mucoepidermoid carcinoma, or is this a hyalinizing clear cell carcinoma without much stromal hyalinization? Immunohistochemistry of a P40 is positive, but it would be positive in both tumors, and there's no immunohistochemical marker to help us to distinguish between these two. So we performed FISH, mammal 2 was normal, and then we performed EWSR1, which shows break apart signal, confirming this to be a hyalinizing clear cell carcinoma. While new entities are emerging, there are some which are also vanishing, like oncocytic carcinoma. As a large subset of this of what was considered oncocytic carcinoma has been found to be oncocytic variants of other tumors. For example, we have here an oncocytic neoplasm which does not show the presence of any mucus cells. However, mammal 2 rearrangement is present, indicating that this is an oncocytic mucoepidermoid carcinoma. And it is now uncertain whether any pure oncocytic carcinomas actually exist that are not morphological variants of other tumors, which is why in the new WHO, oncocytic carcinoma has been moved into emerging entities until further clarity is available on this. Not only molecular testing in salivary gland tumors is not only diagnostic, but it also has a predictive role. The NCCN guidelines state that systemic therapy is increasingly becoming an option for salivary gland tumors with distant metastasis, and biomarker tests should be used to evaluate androgen receptors, NTRK, HRAS, PIK3CA, tumor mutation burden, and HER2 status. HER2 testing is performed as per the ASCO-CAP guidelines for HER2 testing of breast cancers that we're all aware of, so I'm not going to go into that. However, NTRK targeted therapies such as larotrectinib and entrectinib are now available for patients with recurrent NTRK fusion positive salivary gland tumors having distant metastasis. So just let's discuss about this. The ETV6 NTRK3 fusion diagnostic of secretory carcinomas is a targetable genetic alteration. The neurotropic tropomyosin receptor kinase genes NTRK1, 2, and 3 encode for a family of TRKA, B, and C proteins, which are overexpressed whenever there is a mutation in one of these genes, which are seen in secretory carcinomas and also in other solid tumors like colorectal and lung carcinoma and melanoma, as well as in acute myeloid leukemia. Fusions involving these genes lead to oncogenic TRK activation and overexpression of these proteins, and TRK inhibitor drugs block activity of these proteins. These drugs have been approved by FDA for any solid tumor with NTRK gene fusions. And it has been found recently that pan-TRK IHC is a reliable surrogate marker for genetic testing with high sensitivity and specificity, and it serves as a promising alternative, inexpensive screening test. Here we have a case of secretory carcinoma with pleural metastasis. This is the initial cytology and the resection specimen. When the patient developed pleural effusion, the cell block showed a tumor which looked like an adenocarcinoma, however, without any distinctive features. However, we performed ETV6 NTRK3 fusion FISH, and you can see the presence of fusion signals here within the tumor nuclei, indicating the presence of the fusion, as well as pan-TRK immunohistochemistry on the cell block shows nuclear staining. So this not only confirms the diagnosis as metastatic secretory carcinoma, but also indicates that the patient is eligible to receive NTRK inhibitors. Next, we have HRAS mutant epithelial myoepithelial carcinomas. The HRAS codon 61 mutations have been described in about 80% of epithelial myoepithelial carcinomas, but are not seen in those which arise ex pleomorphic adenomas. These are the two different pathogenetic pathways to epithelial myoepithelial carcinoma. The WHO 2022 says that the HRAS mutation is useful for diagnosing epithelial myoepithelial carcinoma and discriminating it from its mimics. Here you can see a classic biphasic epithelial myoepithelial carcinoma, which would not be difficult to diagnose, that shows positivity for RASQ61R immunohistochemistry in the myoepithelial cells. However, here you have an oncocytic tumor, which would have been called an oncocytic carcinoma previously. However, this tumor shows the presence of diffuse RASQ61R positivity, confirming it to be an oncocytic epithelial myoepithelial carcinoma. Not only is this mutation diagnostic, but is also predictive of response to therapy with RAS inhibitors. And this immunohistochemical marker is specific and can help us to identify the specific mutation. Do we have other surrogate markers of immunohistochemistry for all the molecular alterations, salivary gland tumors? Yes, several are available. And for those which are not available, we have FISH probes. So between using FISH and immunohistochemistry, we can diagnose most of these cases, and we do not need to go in for more expensive techniques like next-gen sequencing. However, if we can afford it, we have a number of options, including this, which is an all-in-one RNA-based next-gen sequencing panel, which is suitable for detection of mutations, fusion, and gene expression of 27 genes involved in salivary gland neoplasms, and has been validated on FFPE specimens and cell blocks against results from FISH Sanger sequencing and next-gen. And this has now been expanded from 27 to include the newer genes as well. Can we perform these tests on cytology? Because we know that salivary gland masses are frequently tested by FNAC. Yes, various publications have shown that these FISH can be performed successfully on cell blocks, extra smears, even de-stained smears, as well as the surrogate immunohistochemical markers have also been found to be highly sensitive and specific for diagnosis. However, when we have limited material, it's important to first make a morphological diagnosis and then decide which molecular test we want to perform. Here is a case of secretory carcinoma in which we have performed ETV6 FISH, break apart FISH on an MGG de-stained smear. You can see the split signals confirming the presence of this rearrangement. To summarize, salivary gland neoplasms are a morphologically and clinically heterogeneous group of tumors which present challenges both with diagnosis as well as therapy, necessitating accurate diagnosis for optimal management with surgery, adjuvant radiation, and systemic therapy. Use of molecular testing is rarely essential for the diagnosis of salivary gland tumors, as immunohistochemical surrogates are available, and it is not recommended in cases where morphology and immunohistochemistry are sufficient to make a diagnosis, and the management will not be altered by performing additional testing. So when do we need to perform molecular testing? When immunohistochemistry does not support the morphological diagnosis, such as mucoeps, which are negative for P40, for diagnosis of rare histological subtypes of tumors and morphological variations, like we saw the Warthin-like mucoeps, diagnosis of high-grade transformation to identify that the high-grade transformed portion of the tumor has arisen from the differentiated part of the tumor. Carcinomas, where the histological diagnosis includes terms like undifferentiated, poorly differentiated, or not otherwise specified. And most importantly, when treatment decisions may be altered in locally advanced, recurrent, and metastatic tumors. Lastly, we cover molecular testing in head and neck paragangliomas. We know that paragangliomas have the highest degree of heritability among all human cancers. And most head and neck paragangliomas have germline or somatic mutations in 5 genes that is SDH, A, B, C, D, and AF2. And these genes encode subunits of the heterotetrameric succinate dehydrogenase complex, which is a component of the Krebs cycle and the mitochondrial respiratory chain. Why these mutations are important, and not only do they tell us about the pathogenesis of these tumors, but they are also associated with certain clinical features like SDHD mutations are associated with multifocality, and SDHB mutations are associated with increased risk of metastasis. Importantly, any defect in any of the SDH genes leads to degradation of the catalytic SDHB component, which is why a mutation in any one of the genes leads to loss of SDHB immunostaining. As is seen here, you can see that the tumor cells are showing loss of staining, whereas the endothelial cells and the cystentacular cells are showing positivity. And this immunohistochemical marker serves as an excellent surrogate for mutation in SDH genes. And why it is important is that because since these are heritable, the entire family of the patient with the paraganglioma should be screened for the presence of SDH mutations, as they are likely to develop a number of tumors, including paragangliomas. With this, I will conclude saying that with advances in molecular biology of head and neck neoplasms, the viral-driven malignancies have gained recognition and tumors have become more and more molecularly defined. And molecular diagnostic modalities are now becoming the cornerstone of diagnosis in tumors, particularly those with challenging morphology. The role of molecular testing in head and neck tumors is not only diagnostic but also prognostic and predictive of response to therapy. And as pathologists, it tells us about the pathogenesis of these tumors, which is of great interest to us. There is therefore an increasing requirement for pathologists to provide information beyond standard HE and immunohistochemical stains. However, excuse me, there are many technical and cost-related considerations regarding the implementation of molecular testing. With a narrow differential diagnosis, FISH is the most practical and efficient method for detecting gene rearrangements which are most commonly seen in head and neck tumors. However, for advanced locally recurrent and metastatic malignancies, NGS is preferred as it is a broad panel-based approach which can detect novel fusions and fusion partners. Lastly, results of molecular testing should not be interpreted in a vacuum, but a combination of histology, immunohistochemistry, and molecular results should be included to render the final impression. Thank you.
Ma'am, for your fabulous and crystal clear presentation. I hope most of the residents have learned many things from your presentation. Now, I request our chairpersons, Dr. Rajiv sir and Dr. Darwin sir, to
Thank
take
you.
over the mic.
Thank you, Anchal. It was an excellent update on the head and neck tumors, on especially covering all aspects of the molecular, uh, right from the HPV-related tumors, then covering the sinonasal tumors, and finally about the salivary gland tumors. So I agree. In the head and neck, earlier we used to say the role of molecular is not that much, because predominantly we used to see predominantly squamous carcinomas, and that is the major chunk. But with the advent of molecular test and coming new entities, especially in the Simon results. So it has become a very relevant and essential part of the diagnostic work for the molecular. One point which I like to emphasize, which even Anchal has also emphasized, these most of these, although you may say we don't have this facility for molecular testing, but diagnosis is the pathologist has picked up the morphological clues and then try to segregate. So always use your morphological features, and whenever you come across any such case which is not very conventional squamous or not fitting, so don't leave the case over there, and those cases should be worked up further. Uh, uh, Anchal, any recommendation from your side, especially for the HPV testing? Because as you had told, which is practical for especially for the Indian in Indian perspective related
From
to
the Indian
IST or RNA at least.
Yes. So from the Indian perspective, it is important that we take the cost of the testing and the availability of facilities into consideration. So we have found in our cases that P16 positive tumors, more than 50% of them do not show the presence of HRHPV by mRNA-ish. So if treatment decisions are going to be taken based on P16 status, that is not the ideal way to go, because most of these tumors, half of them are keratinizing squamous cell carcinomas, which do not morphologically look like HPV positive tumors, and they're also negated by mRNA-ish. So in my opinion, we should perform mRNA-ish in positive cases, P16 positive cases, and those should be considered when we are looking at including them in clinical trials for de-escalation therapies.
So, Dr. Darwin, any comment from your side?
Yes. Thank you, Department of Pathology, Dr. Manupriya and her team for giving us this opportunity and excellent presentation, Dr. Anchal Kakkad. I can see how much effort you have put in preparation of these slides. Uh, I witnessed few cases also where I found it is very challenging, particularly in thyroid malignancies, in Ewing sarcomas of zygoma, and some neurogenic tumors also, ganglion neuroblastoma, particularly at hypoglossal canal, level 2. Uh, I just want to ask one question, ma'am. I'm a biggest sufferer in that sense that earlier I was working in Jodhpur and now Bilaspur. So this is a new growing institute. Now, whenever we talk about head and neck tumors, we need a dedicated team. We are very much concerned about cost and availability of instruments. So any tips for this upcoming institute that how to proceed for this molecular testing and how to proceed, how to make diagnosis? Because it is very important for us as clinician to counsel our patients, particularly when we have negative biopsies. We have differences in histopathology also, to early diagnose, to early treat, to have good prognosis, and also in staging. So any tips for this upcoming institute?
So to start with, before we jump to molecular testing, we start with the surrogate immunohistochemical markers. As I mentioned, we have a lot of surrogate immunohistochemical markers which are available, which can detect these molecular alterations. And immunohistochemistry is a technique which all pathologists are well versed with. It can be performed manually, and it does not need to always be performed on automated machines if they are not available. In smaller labs as well, it can be done manually. The next step would be again to go for molecular tests which are required, fluorescence in situ hybridization, mRNA in situ hybridization. These are also not automated techniques. For fluorescence in situ hybridization, you do require an expensive setup of a fluorescence microscope. So that is definitely a huge cost that one would consider, a department would consider purchasing that equipment if they have requirement for a lot of molecular tests. Right now, hematological malignancies, soft tissue tumors, and head and neck tumors have a large number of alterations which can be detected by FISH. So if you're getting large volumes of these cases, then it might make sense that you want to go in for fluorescence in situ hybridization. If you don't have large volumes, then you're not going to require the expensive equipment that is necessary for performing these tests. mRNA in situ hybridization for HPV testing, on the other hand, you don't need an expensive microscope. It's just the routine microscopes that your pathologists are using to see HE stain slides. While it has options for automation on Ventana and other platforms which are more expensive, it can also be performed manually, where it just needs an oven to maintain the temperature. So there are options to starting these techniques with manual procedures rather than going in for the high-end expensive instruments. So first, to standardize these manually might be a good option to see then whether it is serving your purpose clinically or not, and if it is, then you go and look into the more high-end equipment that might be required.
Thank you, Dr. Anchal. We will be taking your help.
Definitely.
Can I make a comment?
Yes, sir.
Yeah, so in addition to what Anchal has mentioned, we do face a lot of pre-analytical challenges. So it is also recommended to all the labs to take care of the tissues very properly, fix them properly, and process them properly, because a lot of challenges are faced, especially in the molecular testing, if the tissue is not properly processed and the fix. So that you can start from the day one, and you don't need any help from any other tertiary care institute for that. So standardization of the tissue processing, fixations, these are very crucial things which you can do right now. And there is one program which is called as a Diamond Labs by Government of India, Ministry of Health, and in which some aims are also being it is working as a hub and spoke model. So there are some aims are also part, like aims Jodhpur is part under TMH, so that you can join that scheme and try to develop the molecular facility in your setup. So that's the one another additional thing we can try to set up the things. And don't as Anchal mentioned, the start go stepwise. From day one, you can't jump into the molecular diagnosis, and you should always try to have a stepwise approach to set up these things.
Thank you, sir.
And the instruments which many institutes got during the COVID time, you should not keep them idle. You can use because the same technology can be used for the molecular diagnosis of others. So we have seen many RT-PCR machines were given by government and set up in the institutes, and now they are lying awake unused. So you can use the same technology for the molecular diagnosis for other indications as well.
Thank you.
Thank you, sir. Thank you, Dr. Rajiv, Dr. Anchal Kakkad, for these wonderful tips for our upcoming institute. Hopefully, they will help us a lot in progressing. Thank you, Dr. Darwin, for your valuable comments. And we are lucky to have Dr. Rajiv. He is a Himachali. He belongs to Bilaspur. So it is an honor to have him here with us. Thank you, sir, for accepting our invitation. And now I would also, yeah.
Yeah,
now I would also.
The part of this first, I think this is the first meeting Path Department.
Yes, sir. This is the first virtual CME that is being organized, and I'm thankful to all the speakers and chairpersons who accepted our request and joined us. Thank you, Anchal ma'am. Thanks a lot.
Thank you.
Now we have another consultant, Dr. Kuldeep Thakur. He is assistant professor in Department of Dr. Anchal is there. Dr. Anchal ma'am, he wants to interact with in this presentation, in this session, Dr. Rajiv and Dr. Darwin. Yeah. So Dr. Kuldeep, he is assistant professor. Yeah. And he's a head and neck surgeon. So he wants to give his comments on this topic.
Hello. Good afternoon, everyone. Good afternoon, ma'am, sir, and everyone. That was a very nice presentation and very informative for all of us who are working in the field of head and neck cancer. This is a very beautiful specialty, upcoming specialty with lot many patients. Just wanted to put few words, few comments because I'm a clinician. So just few words. This is purely a pathological meet. I can understand. With the advent of immunohistochemistry, biggest advantage for us was the diagnosis. Initially, for example, if we talk about sinonasal tumors, initially, lot many undifferentiated tumor or poorly differentiated tumor, we used to classify this as NUC. And now see, after the advent of many immunohistochemical markers and to some extent the genetic studies, we have now so many diagnoses like the one with very poor prognosis like NUT midline carcinoma, IN-I1 deficient, SMOG, other things. So I think this was the biggest thing which helped us a lot. One thing is like not for the treatment point of view, but the important thing is for the prognostic point of view. When this diagnosis, when we diagnose like IN-1 or NUT midline carcinoma, for example, so we can prognosticate patient in a nice way. that we need to have aggressive treatment, and definitely the prognosis is much more better than SNUC. So this was the biggest advantage probably for us and for patients also. Definitely in current scenario, we don't have, with the advent of all these things, we could not change the treatment protocol. Like in oropharyngeal carcinoma, whatever evidence we have so far, we could not de-escalate things, but at least we can, explain the prognosis, good prognosis. That is, I think, a edge that we have so far. But definitely, the other thing is with the advent of molecular things. I think we are not practicing molecular testing routinely nowadays. But definitely, once our palliative, the routine palliative treatment, once it fails, then we definitely go for all those things. Like for the genetic changes, where we want to subject patients for the targeted therapies, especially salivary gland tumors. We have many new targeted therapies, but I think currently we don't have any evidence where we can de-escalate things based upon IHC findings, or we can change our treatment based upon the IHC things and other. But prognosis is the important edge that we have right now. So yeah, and the other thing which I want to ask Anchal ma'am is regarding the upcoming edition of WHO 5th edition. So would you please throw some knowledge on a few words on this thing, that what drastic things we are expecting in as far as the head and neck cancer is concerned in upcoming WHO 5th edition?
So nothing drastic. The WHO 5th edition is available online and the print should be out soon. A lot of new entities which are defined genetically, which we have known about for the last few years. We've seen articles and reports on them. Those have now been included as, distinct tumors, like you mentioned, SMARC A4 and SMARC B4 deficient, which were previously called SNUC. So now they are distinct entities which are defined genetically in the sinonasal tumors group. Same thing in the salivary gland tumors, we have newly identified entities which are coming in. And there has been a little shift in nomenclature in some of the tumors, but no drastic changes, nothing like the previous where oropharyngeal cancers were changed, separated completely from oral cancers. So I think we're all quite aware of what are the changes to expect. But the most important thing is that the molecular alterations are being used to define entities, and they are included in the previous editions of WHO did not have these essential and desirable diagnostic criteria. The 5th editions of across all tumors, not only head and neck, have these essential and desirable criteria. So these molecular alterations have found their way into this essential and desirable diagnostic criteria. So that is, I think, a very important change that we are seeing in the 5th edition.
Yeah. Thank you very much.
Dr. Anchal, thank you, Dr. Kuldeep, Dr. Darwin, and Dr. Rajiv for your valuable comments. Thank you. Yeah. So now we move on to the next session. Next session is on role of molecular pathology in endometrial carcinoma. This session will be taken up by Dr. Pariksha Gupta. She is Associate Professor in the Department of Cytology and Gynec Pathology, PGI Chandigarh. She has a total experience of, please mute yourself. Anyone whose mic is on, please mute yourself. Please. Minimize कर दो. Minimize कर दो कोई ना. It's a humble request. Please mute yourself. So, she has a total experience of 13 years, and her areas of interest are cytopathology, gynec pathology, and molecular pathology. She has a lot of major achievements, like she is a diplomat of the International Academy of Cytology. And she has written more than 120 international and national publications. इसको minimize कर. Next, The chairpersons for this session are Dr. Nalini Gupta. She is Professor, Department of Cytology and Gynec Pathology, PGI Chandigarh. She has more than 340 publications in journals of international and national repute. Ma'am has written many book chapters, and her areas of interest are cytopathology, liquid-based cytology, lung and gynec pathology, and cancer research. She has a membership of a lot of editorial boards, and she has received the best IASLC award, the Lung Cancer Care Team Award 2019. She has a very keen interest in LBC, and she has done a fellowship in Manchester Cytology Center, UK, and she has experience of conducting more than 30 workshops on LBC. Next, the chairperson for this session is Dr. Poojan Dogra Marwaha. She is additional professor, Department of Obstetrics and Gynecology, AIIMS Bilaspur. She has her field of interest in gynec, laparoscopy, oncology, high-risk pregnancy, and she has published articles in numerous national and international journals. She is investigator in numerous institutional projects, and she is a thesis guide for many primary and secondary DNB students. So now I request Dr. Pariksha Gupta to please start with her presentation. Dr. Pariksha Gupta, ma'am.
Yes, I will just share my screen. So
Sure, ma'am.
good afternoon to all of you. So thank you, the organizers, especially Dr. Manupriya, for providing me this opportunity. So is my screen visible?
Not yet, ma'am.
Not now?
Yeah, it is visible, please. Yeah.
So the topic that has been given to me is the role of molecular pathology in endometrial cancers. So since we have all highlighted that molecular pathology goes hand in hand with the histopathology, so I will be in the next 30 to 40 minutes, I will be covering first the classification of endometrial cancers. Briefly, I'll be discussing the major histopathological types of endometrial cancers, followed by the advantages as well as the limitations of the histopathological classification, the need for the molecular testing, and then in detail, we will discuss the role of molecular testing in endometrial cancers. So endometrial cancer, as we all know, is the most common gynecological malignancy in the developed world. It is the fifth most common cancer worldwide. And majority of these cases are sporadic, while 10% of the cases are familial or have a genetic background. So traditionally, endometrial cancers, they have been classified as type 1 and type 2. These prototype examples being the endometrioid for type 1 and serous carcinoma for type 2. So this table shows the differences in the clinicopathological profiles. The major ones being the in frequency. The type 1s are much more common. They are more common in obese women and are associated with hyperestrogenism. The tumor grade and stage are often low as compared. This is in contrast to the type 2, where the prototypical examples are the serous, the clear cells, and the carcinosarcomas, where the tumor grade, the tumor stage, and myoinvasion are often deep. The prognosis is hence similar, and the 5-year survival rates are higher in type 1, while they are much lower in type 2 endometrial cancers. So this is the table that is showing you the common genetic alterations in type 1 and type 2. And we can see that these alterations are much more common. The PTEN, PIK3CA, KRAS, ARID1A, and beta-catenin mutations and the MMR deficiencies, they're much more commonly encountered in type 1 endometrial cancers as compared to the type 2, where TP53 and HER2 amplifications are common. So this is again the same thing, where we can see that grade 3 endometrioid carcinomas and uterine serous carcinomas, the type 2 and the grade 3 type 1s, they are commonly associated with TP53, while others are different. So coming to the WHO classification, so briefly, the major difference in the newer WHO classification from the previous 4th edition is that the 4th edition is based on the histological as well as the immunohistochemical characteristics of various endometrial cancers, while the 5th edition that has recommended and basically incorporated the molecular classification along with the histopathological parameters, and it is basically the histomolecular classification. And this is the list of tumors that have been included. The most important change is in terms of these 4 subtypes that are molecularly defined. So we'll be discussing them soon. So since this CME is targeting the residents, so I thought I will just briefly discuss about the grossing part. So most commonly we receive total abdominal hysterectomies and bilateral salpingo-oophorectomies with omentectomies and with or without lymphadenectomy specimens. So on gross examination, these are the important features that need to be looked for. The outer surface, the internal, on bivalving the uterus, we have to look for the internal surface, the exophytic or the infiltrative tumor, whatever is the pattern. And then we have to identify the size, measure the size of the tumor, the location of the tumor, whether there is any ulceration. And after bivalving, we have to make serial slices, and then we have to carefully assess the myometrial invasion. This is the most important thing that has to be assessed on gross morphology, besides the assessment of other parameters. So this is the diagrammatic representation. We bivalve the uterus like this. We examine, note all the findings, the internal surface, the outer surface, the cut section. Then we bivalve the uterus, and then we give serial slices so as to examine the myometrial involvement, the depth of the myometrial invasion. This is the actual specimen, and here we can see this is the tumor infiltrating into the myometrium. Now, how do we assess the myometrial invasion? We have to identify the endomyometrial junction first. So this is the thickness of the A represents the thickness of the myometrium. This is the tumor thickness. This whitish thing is the tumor, and this is the distance, tumor-free distance from the serosa. So basically, this C is representing the myometrial depth of the myometrial invasion, and you have to grossly, at least if not in terms of centimeters, you have to assess whether it is more than or less than 50% of the total myometrial thickness. So coming to the microscopy, so microscopically, what all do we need to specify in our reports is the histological type or the subtype, the grade of the tumor, the depth of the myoinvasion again has to be confirmed on microscopy, the presence of lymph node involvement, lymphovascular space involvement, serosal involvement, and cervical involvement, especially in terms of stromal involvement. And we also have to comment on the adjacent endometrium, whether it is atrophic, hyperplastic, or it is showing secretory changes. So this is important. These microscopic features are important because all of these have an impact on the staging. And we can see that the thickness of the myometrial involvement has an impact on staging. Cervical stromal involvement, similarly serosal involvement, and lymph node involvement also. So briefly about endometrioid carcinoma. Endometrioid carcinoma is a predominantly glandular tumor that lacks the nuclear features of endometrial serous carcinoma. It is much more common and accounts for 60 to 70% of the endometrial cancers. So these are the morphological features. So someone is trying to share. I am just declining the request. So these are the morphological features. The tumor cells are predominantly arranged as glands, and there is desmoplastic stroma surrounding the glands, which is basically the bluish endometrial stroma is replaced by the fibroblastic stroma. The tumor cells are columnar, stratified, and they have variably coarse chromatin and prominent nucleoli. Additional features that may be noted include squamous differentiation, morular differentiation. The squamous differentiation is different, as we have to identify keratinization or intercellular bridges, then only we label it as squamous differentiation. Otherwise, solid nests, they are just referred to as modules. So, POM cells are also quite commonly seen in the endometrioid adenocarcinomas in the stroma. So these are the images showing the typical morphological features. So now coming to the grading. So according to the WHO classification, both architectural and nuclear grades have to be provided in our report. So what is architectural grading? It is based on the proportion of the glandular and the solid arrangements. So what is nuclear grading? It is just the degree of nuclear pleomorphism, mild, moderate, or severe. And so the important point to remember here is the architectural grade is always much more important than the nuclear grade. And only if the nuclear grade is significant, is severe, then only the total grade will be upgraded by 1. So I will explain this by some examples. So this is a tumor predominantly arranged in glands. The nuclear grade also seems to be low. So architectural grade 1, nuclear grade 1, the overall grade is also 1. So this is again predominantly glands, but some solid nests and cribriform arrangement. So architectural grade 2, nuclear grade again 1. So this again goes as grade 2. The architectural grade was 2 there. So this is architectural grade 3, predominantly solid pattern, and nuclear grade is again low. So this will be architectural and grade 3. So final grade will be 3 here. So now this tumor has a grade, architectural grade of 1, but the nuclear grade is like 2. It is the moderate nuclear pleomorphism. So the overall grade will not be increased. It will be based only on the architectural grade. Had it the nuclear grade been 3 here, so we would have upgraded the grade to 2. So then myoinvasion has to be characterized, as we have already discussed. Then squamous differentiation. So it is important to clearly differentiate squamous differentiation from the solid areas, because the solid areas that have to be assessed for grading, for the architectural grading, they should be non-squamous and non-morular. So squamous areas should not be misinterpreted as the solid tumor nests. So then we have to assess lymphatic and vascular invasion and cervical stromal involvement, because they have implications on the staging. So immunohistochemistry. So low grade and high grade endometrioid adenocarcinomas, they have characteristic immunohistochemical phenotypes. The low grade ones, they show strong and diffuse nuclear positivity for the hormonal receptors, that is the ER and PR, and they may show patchy positivity for P60, and nice basolateral membranous positivity for vimentin is there. While the high grade ones, they have loss of immunoreactivity for ARID1A, P10 and MMR proteins. And in around 20% of the cases, they can show, 20 to 30% of the cases, they can show P53 abnormal phenotype. So coming to the genetic profile, we have already seen that P10, PIK3CA, ARID1A, KRAS, and in 20 to 30% of the cases, TP53 mutations can be seen in endometrioid carcinomas. Next is the serous carcinoma. So this is the prototype type 2 carcinoma, highly aggressive, poor prognosis, low 5-year survival rates, and fortunately they account for only 10% of the endometrial cancers, most commonly seen in postmenopausal age groups, and have high propensity for deep myoinvasion, extrauterine spread, lymphovascular space involvement, and metastasis. So microscopically, they are characterized by predominant solid or papillary pattern, and there is marked nuclear pleomorphism. So the nuclear grade in serous carcinoma, in uterine serous carcinomas, is always high. It has to be high. Besides that, there can be detached cells present in the spaces. So these are the detached cells in the second image, and they rarely they can have a glandular predominant morphology also. So on immunohistochemistry, the most important marker for serous carcinoma, uterine serous carcinoma, is the abnormal P53 expression. Either it can be the mutant type expression, which can express which can be in the form of overexpression, or a null phenotype. That is either more than 75 to 80% of the nuclei, tumor cell nuclei, are showing positivity, or none of the nuclei are showing positivity. Besides that, WT1 expression is variable in uterine serous carcinomas, and this is a useful feature to distinguish it from the serous carcinomas of the tubo-ovarian origin, where their WT1 is much more diffuse. So this is just to show you the diffuse mutant type overexpression P53 in serous carcinoma. So sometimes it becomes difficult on morphology to differentiate serous from endometrioid adenocarcinomas. Then the important thing again comes is the TP53 expression, which favors serous carcinomas, although it can be seen in. So the important thing to be remembered is, although it can be still be seen in 20 to 30% of the high grade endometrioids. So rarely true mixed tumors wherein there is a component of serous carcinoma coexistent with endometrioid carcinomas can also be seen. There also we will see differential expression of the immunohistochemical markers. So was from one such case where it was on morphology. It was difficult to identify whether it is a serous carcinoma or an endometrioid carcinoma. However, the immunohistochemistry for P53 and IMP3 helped us in distinguishing in identifying it as a serous carcinoma rather than a endometrioid carcinoma. So next is the clear cell carcinoma. So clear cell carcinoma, we all know it has that solid tubulocystic pattern. It can have abundant clear cytoplasm with hobnailing, sometimes eosinophilic cytoplasm also. So in majority of the cases, clear cell carcinoma on immunohistochemistry, P53 will be negative, and the tumor cells, they are positive for HNF1 beta and napsin A. So this is the tubulocystic pattern in clear cell carcinoma, nice hyaline globules in the center, abundant clear cytoplasm, hobnailing, and again, some faintly eosinophilic cytoplasm. So besides these histotyping, there are certain histological predictors of prognosis. So besides diagnosis, there are histological predictors that can help in assessing the prognosis also. So this is the list of prognostic factors. So out of these, the most important ones are the histological type, the histological grade, depth of myoinvasion, age, and the FIGO stage. So based on myoinvasion, we can see that as the myoinvasion increases, the 5-year survival rate goes on decreasing. So now coming to the advantages. So we are doing so many things on the basis of histopathology and immunohistochemistry alone. So what are the basic advantages? So diagnosis. It helps us in establishing the diagnosis, and this diagnostic thing, as we have seen in the staging, this carries prognostic implications also. So we can prognosticate the patients also, and we can also help in therapeutic decision making. Whether it is a serous carcinoma, it needs a high grade kind of treatment, needs some adjuvant therapy or not. So by the virtue of histopathological and immunohistochemical evaluation itself, we are providing a lot of information, diagnostic, prognostic, as well as therapeutic information to the clinicians or to the oncologists for management of the patients. So you may ask me, is histotyping and grading of the endometrial carcinomas enough for risk stratification and therapy? So I would say no. Why? I would like to tell you the challenges that we face with histopathology and immunohistochemistry alone. So studies have shown that there is poor inter-observer reproducibility. So if there is poor inter-observer reproducibility in terms of histotyping and grading of the tumors, it leads to under-treatment, and it leads to misdiagnosis, and it leads to under or over treatment of the patients. So similar histological, it has been seen that tumors with similar histological patterns, they have significantly different clinical behaviors. So this cannot be explained on the basis of immunohistochemistry or histopathology. There has to be a genetic or a molecular basis to this kind of variation. So all this often leads to poor risk stratification. If we have misdiagnosed a case as serous instead of endometrioid, so the patient goes to the high risk category and is offered unnecessary aggressive treatment instead of the fertility sparing surgery that she could have easily received. So all these challenges were there. So there was a great need to obtain reliable biological informative data from the endometrial tumors that could assist in appropriate planning and optimal treatment of these patients. So thus came the molecular classification, and that is why WHO has incorporated the molecular classification with the existing histopathological parameters to form this histomolecular classification. So this is there were a lot of papers that have shown poor inter-observer reproducibility, and tumors had been misdiagnosed. So now coming to the role of molecular pathology, I already told you it helps in terms of diagnostics. It helps in objectifying the diagnostics. It provides reliable prognostic information and better therapeutic decision making. So what are the roles in diagnostics? The molecular pathology, how can molecular testing help in diagnostics? It minimizes the inter-observer variability. It helps in diagnosing patients who are suspected of having Lynch syndrome, and it helps in reliably subtyping the endometrial cancers for further risk stratification. So coming to Lynch syndrome and endometrial cancer. So Lynch syndrome, we know, is a hereditary cancer-related syndrome, which is caused by the germline defects in DNA mismatch repair genes. And the patients harboring such germline mutations, they have a predilection for development of tumors at various sites, including colon, rectum, large bowel, endometrium, stomach, ovary, pancreas, and ureters. So endometrial cancer is quite common, as contrary to the earlier belief that colonic cancer is one of the most common malignancies. Endometrial cancer is also quite common, and 40 to 60% of these Lynch syndrome patients can have endometrial cancers, and it can be an index malignancy in around 50% of these cases. So the germline mutations most commonly occur in the MSH2, MSH6, MLH1, and the PMS2 genes. And in sporadic cases, MLH1 promoter hypermethylation is the basic cause. So how do we test? How do we diagnose Lynch syndrome in endometrial cancers? So the screening modality is the immunohistochemistry that is used as a surrogate for the detection of the microsatellite instability. If immunohistochemistry is not available, it is a much cheaper alternative. But if it is still not available, then the samples, they can be outsourced to the other private laboratories or other laboratories which are performing molecular MSI assays. So MSI assays and or immunohistochemistry can be performed for the detection of the mismatch repair deficiency. So there are certain clinical and histological clues that if recognized in a particular patient, we can follow an algorithm to help confirm the presence of Lynch syndrome in that particular patient. So endometrial carcinoma, if noted in a woman less than 40 years of age with family history of colorectal or endometrial carcinoma, and if that tumor is mostly arising in the lower uterine segment with on histology is showing abundant tumor infiltrating lymphocytes and has a poorly differentiated morphology, such features they usually favor. They are commonly noted in Lynch syndrome associated endometrial cancers. So this is the algorithm that needs to be followed if we are suspecting a Lynch syndrome in a particular patient. So we have to assess the loss of MMR, mismatch repair deficiency, by immunohistochemistry. So we usually put test for two markers because it has been seen that the isolated loss of MSH6 and PMS2 is quite confirmatory for germline mutations in these genes. So we first of all test for these two markers, and if there is any of these is showing a loss, then we can confirm the other by performing the immunohistochemistry for other two. So if there is any mismatch repair deficiency, then confirmation has to be done by germline testing for these genes. So coming to the utility in prognostication, so molecular testing can help perform the molecular subtyping, which divides these endometrial cancers into distinct prognostic groups that have that help in reliably risk stratifying these patients, and thus provide the standardized treatment recommendations. They also provide guidelines for surveillance and decision regarding fertility sparing and administration of adjuvant therapies. So basically, the molecular pathology in endometrial cancer started the interest was generated mostly in 2013 when the Cancer Genome Atlas network, they performed integrated genomic, transcriptomic, and proteomic analysis of around 400 endometrial carcinomas, and they identified four different molecularly distinct groups that they found to have different prognostic implications. So this was the basic data. So they found that of all the 373 patients which had mixed morphologies, both the endometrioid serous as well as mixed carcinomas, they were included. They identified four clusters. On cluster analysis, they found four distinct clusters. So the cluster 1, it showed it was devoid of any somatic copy number alterations. And the cluster 2 and 3, they mainly consisted of tumors that were showing frequent 1q amplification. And the cluster 4 was mostly composed of serous and mixed histology tumors, and it most commonly showed P53 alterations. So basically, then they evaluated the individual genes in these four groups, and they identified that there were four distinct types: the pole ultramutated, or the MSI deficient, the MSI unstable or the hypermutated group, the copy number low or the endometrioid-like group, and the copy number high or the serous-like group that showed distinct genetic alterations. So these are the most common genetic alterations that were noted. So we can see that the ultra mutated group or the pole ultra mutated group that most commonly shows us the pole EDM mutations, the exonuclease domain of the polymerase epsilon mutations, followed by the PIK3CA and PTEN mutations. While the hypermutated group, it commonly hypermutated and the low copy number groups, they share mutations in the PTEN, PIK3CA and the MMR genes. While the high copy number alterations or the serous-like ones, they are most commonly showing the alterations in TP53 gene. So then this can be tested by following an algorithm that first of all, for any newly diagnosed case, we can test for a pole mutation, that is mutation in the exonuclease domain of the polymerase epsilon. If the patient is wild, then the patient can be tested for mismatch repair deficiency by immunohistochemistry or directly for microsatellite instability by performing the MSI assays. If the patient is microsatellite stable, if it is unstable, then it goes into the MMR hypermutated group. If it is stable, then we have to perform TP53 mutation analysis by either immunohistochemistry or sequencing to identify if it is TP53 abnormal, then it goes into the copy number high group. And if it is TP53 wild type, then it goes into the copy number low group. So basically this copy number low group, or also referred to as the no specific molecular profile group, is the diagnosis of exclusion. So then they also performed the Kaplan-Meier curve analysis, and they assessed that in terms of progression-free survival, the progression-free survival was highest for the pole ultra-mutated group, followed by intermediate for the MMR hypermutated group and the specific molecular profile, while it was the lowest for the copy number high or the serous-like or the TP53 abnormal group. These are the three names for this particular group that has frequent TP53 alterations. So this is the summary of this thing, that these four groups, they carry different prognosis, they correlate with progression-free survivals, and the important finding was of a pole ultra-mutated identification of the pole mutations in endometrial cancers. So coming to the pole ultra-mutated endometrial cancers, they account for less than 10% of all endometrial cancers. They're known as ultra mutated because they carry a very high mutation burden. Per megabase, there are more than 100 mutations. So these are one of the most common solid tumors that carry such high mutation burden. And hotspot mutations are basically in the exonuclease domain of the polymerase epsilon that is involved in DNA replication and repair. So it is the EDM, the exonuclease domain mutations in the polymerase epsilon. Besides that, other mutations can be noted in PTEN, PIK3CA, and KRAS. These are most commonly younger patients with low BMI, no non-obese patients, so they do not have any association with hyperestrogenism. Although they have aggressive pathological features that they resemble, they are mostly high-grade tumors, but they carry excellent prognosis and have high survival rates. So there are studies that have shown that these 10% of the cases, these 10% of the endometrial cancers that show pole mutations, they do not need any adjuvant therapy besides the usual surgery. The major disadvantage with this group is that there is no surrogate immunohistochemical marker available till date, and PCR-based testing or the sequencing has to be performed for identification of this particular group. So coming to the hypermutated or the microsatellite unstable tumor group, this is characterized by defects in the DNA mismatch repair system. We already know the names of the mismatch repair genes, and based on the defects, they can be classified as mismatch repair deficient or proficient tumors. So this group includes the mismatch repair deficient tumors. And the deficiency can be either because of the germline mutations, wherein the tumors are basically a part of the Lynch syndrome. It can be because of somatic mutations or epigenetic changes. In case of somatic mutations and epigenetic changes, the tumors are mostly sporadic. So these account for 25%, around 25%, 25 to 30% of all endometrial cancers belong to the MMR deficient group. And these are obese patients, middle-aged females, and they often show extensive lymphovascular involvement with lymph node and lymph node spread. These are candidates for immune checkpoint inhibition, and it is important that we, in patients with subclonal MMR loss, we should test these cases for promoter hypermethylation of the MLH1 gene, because most of those cases would not fall into the Lynch category. They would be because of the sporadic. This is the algorithm for the Lynch. We've already discussed this. This was from one of our own studies wherein we performed the immunohistochemical analysis for the mismatch repair genes in endometrial cancers. This is from a case that is showing all retained mismatch repair protein expression. And in this case, there is loss of expression, nuclear expression for MLH1 and PMS2, while the MSH2 and MSH6 expression is retained. And so this is another case which is showing loss of MSH2 and MSH6, while the expression for MLH1 and PMS2 is retained. So it is important to remember that these proteins are often lost in pairs. The MLH1 goes along with MSH2. However, isolated loss of MLH1 can also occur, and it is most commonly due to the epigenetic alterations, the promoter hypermethylation. And similarly, MSH2 goes along with MSH6. There is paired loss. However, MSH6 alone can also be lost. That is the basis of the two marker testing. That is why we use MSH6 and PMS2, because they can also be, because the isolated identification of the isolated loss of these markers is a direct evidence for the high suspicion of Lynch syndrome. So coming to the third category, that is the copy number high or the serous-like tumors or the P53 abnormal group. They are characterized by extensive somatic copy number alterations. They have low mutation rates per se, but the somatic copy number alterations are very high. And the most frequent genetic alteration is the TP53 mutation. And these tumors, as we all know, are characterized by high-grade, advanced stage, serous and clear cell and carcinosarcoma morphologies. And destructive growth pattern are more common in elderly, postmenopausal, non-obese women and have aggressive course and poor clinical outcomes. Now coming to the last category, that is the copy number low or the endometrioid tumor or the no specific molecular profile group, which is basically, as I told you, is the diagnosis of exclusion when none of these alterations are identified. The TP53, neither there is TP53 mutation, nor there is MMR deficiency, nor there is pole exonuclease domain mutation. So then these tumors are classified into endometrioid or the copy number low group. And this accounts for around 30 to 40% of all endometrial cancers. So almost 50%. And these are obese patients commonly associated with hyperestrogenism. And most of these are low-grade, low-stage tumors. However, presence of beta-catenin mutations in these tumors imparts a poorer prognosis to this particular category. So this is just to show that the endometrioid adenocarcinomas, so this is the molecular groups are basically heterogeneous. So it is not that only one particular histotype will be fitting into one particular molecular category. So the endometrioid histotype based on the grade can go into different molecular categories. So the grade 1 endometrioids basically mostly comprise of the go into the copy number low groups. Similarly, the grade 2s also, while the grade 3s, they are most commonly the MMR deficient groups. So grade 3 endometrioids mostly go into the MMR deficient groups. Similarly, serous and carcinosarcomas, they are most commonly included in the copy number high or the serous-like or the TP53 abnormal groups. So then after the TCGA group, PROMISE study came, and then they used surrogate markers, immunohistochemical surrogates. As we have already discussed, immunohistochemical surrogates are used to actually classify these endometrial cancers into different molecularly distinct groups. So only thing is pole exonuclease domain mutations till date cannot be recognized by any immunohistochemical surrogate. So this promise group, they basically said that MMR deficiency can be evaluated first of all, followed by the pole EDMs, then P53, and the rest can go into the no specific molecular profile group. So they also found that the overall survival, the disease-specific survival and progression-free survivals are all high for the whole ultra-mutated groups, followed by those for the copy number low and the MMR deficient groups, while it was worse and it was the lowest for the TP53 abnormal or the copy number high groups. And the findings were very similar to those observed by the TCGA group only. And this is again showing the heterogeneity. So each molecular group has tumors of all different histotypes. The broad lines show the most common morphology that is included, most common histopathological type that is included in a particular molecular type. Like the no specific molecular profile, most common type included is the low-grade endometrioid carcinomas. In the MMR deficient, it is the high-grade endometrioid adenocarcinomas. In the pole ultramutated, they are commonly the high-grade endometrioids or the dedifferentiated endometrioid. As we already mentioned, that the pole ultramutated ones have high-grade histological features, but they have excellent prognosis. So similarly, the P53 abnormal groups, they include the high-grade endometrioids, the clear cell carcinomas, the serous carcinomas, and the carcinosarcomas. So, the important thing to note is the presence of more than one molecular alteration. That is, sometimes when we perform testing, a particular endometrial cancer can show you MMR deficiency as well as a TP53 abnormality. So where to assign such a tumor now? So if we go by the algorithm, so we need to remember that TP53 testing is done last of all. This is because it has been seen that endometrial cancers with subclonal TP53 IHC, they behave, and any other additional mutation, they behave more like the additional mutation rather than the TP53 mutation. So if there is coexistent TP53 with MMR deficiency, the tumors will behave like MMR deficient tumors rather than the TP53 positive tumors. So we have to follow the algorithm for testing, and TP53 mutation testing should be performed last of all. So what is the importance of basically this molecular classification? What is the utility? The most important utility is the development of the international standardized guidelines for management of patients with endometrial carcinoma. So because of this classification, we have now been able to formulate these guidelines for identification of patients with Lynch syndrome and for further risk stratification. So now the patients, they can be, based on the molecular classification, they can be easily categorized into low risk, intermediate risk, high intermediate risk, high risk, and advanced metastatic groups. And they have also provided us significant, they have also provided us the this 5-year survival rates and therapeutic guidelines for these particular patients. So like we can see, for the low risk group, no adjuvant therapy is needed. Only hysterectomy and adenexectomy, bilateral salpingo-oophorectomy is enough. No adjuvant therapy is recommended. But for the intermediate group and the high intermediate groups, brachytherapy and lymphadenectomy may or may not be done. But for the high risk group, we have to add a lot of modalities in addition to surgery. So this is the major advantage. They have provided us now standardized guidelines regarding the treatment also, and there are distinct prognostic criteria now available with us for risk stratification of the patients with endometrial cancers. So now, what are the advantages of the histomolecular evaluation? Till now, I've told you the challenges and the advantages of the histopathological evaluation in endometrial cancers. So this is to summarize that we have come to know the different mutations. Then the mutational frequency is the highest in pole ultramutated group. The somatic copy number alterations are highest in the TP53 abnormal group. And in the pole mutant group, the the most common mutation is the pole exonuclease domain mutation, followed by P10 and PIK3CA in the no specific molecular profile and MMR deficient group, and TP53 abnormality is the most common in the copy number high group. So now coming to the diagnostic tests that can be used, as I've already told, the pole group, the pole mutations, they can be recognized only by the PCR based methods. So either we have to do Sanger sequencing or next generation sequencing to identify these mutations. So the MMR deficiency or the MSI microsatellite instability, it can be identified by firstly by the immunohistochemistry, wherein we can identify the lack or the retention of the protein expression, or we can directly perform the MSI assays, and tumor mutation burden can also be analyzed by NGS. Then fourth is the TP53 abnormal group, wherein we can do TP53 assessment by immunohistochemistry or by sequencing. So treatment implications we have already noted. Now molecular abnormalities. So this table is summarizing the different the molecular abnormalities in the major histological categories. So we know that the low-grade endometrioids mostly will fall into the pole ultramutated, followed by the hypermutated group and the copy number low groups. The high-grade endometrioids will go into the pole ultramutated, hypermutated, the MMR deficient, or the copy number high is also, because 20 to 30% can have TP53 mutations also. The serous ones will exclusively go into the copy number high group, and the no specific the clear cell carcinomas, they have not tested for that. So to conclude, the take home message from my talk will be, although histopathological examination and IHC are helpful in providing useful diagnostic, prognostic, and help in therapeutic decision making, these carry considerable limitations. We have observed poor inter-observer reproducibility in terms of grading and histotyping, and this is a major drawback as it can lead to misdiagnosis and hence unnecessary under or over treatment of the patients. Furthermore, histologically similar endometrial cancers often show significant differences in clinical behavior, and this cannot be explained merely by the histopathological examination. So the molecular basis is essential to determine, and the TCG and the PROMIS groups, they have identified 4 distinct endometrial carcinomas that carry distinct prognostic and therapeutic implications. These groups are, as we know, pole ultramutated, or the the second one is the hypermutated or the MMR deficient. Third one is the copy number low or the no specific molecular profile group. And the fourth one is the TP53 or the serous like or the copy number high group. Immunohistochemical surrogates can be used to reliably identify these molecular subtypes in routine diagnostic laboratories, and only exception is the pole ultramutated group for proper risk stratification, prognostication, and therapeutic decision making. Thank you.
Thank you, Dr. Pariksha, for this nice, wonderful talk. Now I request Dr. Nalini Gupta ma'am to please give her valuable comments. Nalini ma'am.
Yeah, hello. Can you hear me?
Yes, ma'am, you're audible.
Yes. So first of all, I would say for me, it's like icing on the cake. Dr. Manupriya, you are our student and you're doing very well, establishing a new department and collecting gross specimens for the museum, teaching undergraduates, and now doing this CME. And I thank you for involving me for the CME. And secondly, Pariksha, like she is our uh, junior faculty member, and you've witnessed her caliber and the way she has covered CA endometrium right from WHO classification, molecular classification, and she has touched upon the challenges that you can have multiple markers in a particular tumor. So I would say, like, I'm really delighted to be part of this CME, and I think Pariksha's talk was really good. So maybe we can ask for some questions or something in case we have some queries in chat box.
Please, audience, if any query you have regarding this session, please pour in your questions in the chat box. Ma'am, for now, we don't have any question for this session. So
Okay.
we have a question answer round in the end. Hopefully by then, if we have some questions, then we will have
Fine,
those.
fine.
Yeah.
So well done, Pariksha. Good.
Thank you, ma'am. Dr. Poojan, ma'am, she is additional professor in Department of Gynae. Yes, ma'am, please.
Yeah, okay. So, Dr. Pariksha, I think a very well elaborated talk. I think we as gynecologists also learned a lot, uh, especially the, slitting of the uterus. We do it in the center, we've been doing it, cutting the uterus from the side. The side was something which is new to me. But in any case, I think this molecular pathology, it's a new insight, and I hope to start this in the institute itself, so that we're able to give a more, holistic approach to the treatment of the patient in terms of both the, diagnosis, therapeutic, as well as prognostic factors. They're an important ingredient to it, because till now we were just relying on the major, pathology, and even the histochemical analysis was not very elaborately done in most of the institution. Actually, it's not done. So it's purely the pathological diagnosis on which we rely on to further give the treatment to the patient of CA endometrium. So I think you've really elaborately discussed all these newer markers, so that we hopefully by our pathology department, I think we'd like to have this kind of an incorporation, so that we are able to give a more holistic approach to our patients. So thank you very much, Dr. Pariksha.
Thank you, ma'am. Now we are waiting for so now we will be starting with our last session, that is on molecular pathology, basic techniques overview. This lecture will be taken by Dr. Prateek Bhatia. So Dr. Prateek Bhatia, unmute karna sabko.
Yeah, hello, good afternoon, everyone.
You could have not asked anyone else except Dr. Prateek Bhatia, with his vast experience in molecular pathology. He is in charge pediatric hematology oncology molecular laboratory at Advanced Pediatric Center, PGI Chandigarh. He has numerous publications, a vast experience, and his expertise is in genomics, inherited iron-related anemias, and pediatric BALL genomics. The chairperson for this session is Dr. Anita Tehlan, ma'am. She is professor, Department of Pathology, GMCH 32, and she has received the Professor R. Nath Gold Medal for Best Published Research in 2000 at PGI Chandigarh. She has been a laboratory assessor, both external and internal, and she has numerous publications, international and national, as well as she has written many book chapters. Next, for this, we have Dr. Pulkit Rastogi. He is Assistant Professor, Department of Hematology at PGI Chandigarh, and he has numerous publications. He has done DM in hematopathology at PGI Chandigarh, and his areas of interest are leukemias, histopathology of lymphoid neoplasms, molecular hematology of myeloid neoplasms, and laboratory automation. So I request Dr. Prateek Bhatia to please start with his talk. Thank you.
So thank you to the chairpersons, Professor Anita and Dr. Pulkit, and thank you, Manupriya, this kind invitation and for the kind introduction. So just give me a moment, I'll share with my slides. So is my screen visible? So is my screen visible and am I audible clearly?
Yes, sir, your screen is visible and you are audible.
So, right. So, thank you so much. So, it gives me immense pleasure to be talking today about, basic molecular techniques and terminologies because, as we all know, that molecular science has really revolutionized the field of, not only pathology, but many other specialties over the last few decades. And I think it's the right time that we continue with such CMEs where we can discuss about the basics. So it's important for the understanding of new residents and postgraduates. I hope I can make the basics clear, and I'll start with the basic outline of the different terminologies and the then taking up the different techniques one by one. So, as we all know, that there are different omics which are commonly discussed out in when we talk about genomics, and if we look them up, so if we look at the DNA, we are talking about the genomic part. If we look at the RNA, we are talking about the transcriptomic. If we are looking at the proteins, we are talking about proteomics. Or if we are looking at the metabolites, we are talking about metabolomics. So the question is, scientific question. DNA tells us what can happen, whereas RNA tells us what appears to be happening, and proteins tell us what makes it happen, and metabolites what has happened or is happening in our body. And we all know that the DNA code is the A, G, C, T, which are the four different nucleotides, and these code for a three-letter code for the mRNA, which is then transcribed into different proteins. And this is the central dogma wherein the DNA transcribes into mRNA and which is further processed into or translated into a protein. And if we look at the DNA structure, we can see that it's a double helix, which is then bounded upon by different proteins which are termed as the histones, which are basically an octamer complex. And if you look at the metaphase part of the the cell and arrest the DNA there, you'll find them appearing as the chromosomal highly compact DNA structures. So what is usually confused is what is the difference between a gene, loci, or alleles. So if I have to talk about this pair of chromosome 1, so we can look at a particular region in the chromosome 1 that would be a particular loci for chromosome 1. And this loci may have one or multiple genes within it. Now, gene is a segment of DNA which codes for a particular protein, and the genes on both these homologous chromosomes, if they are similar, it's the wild type. And if they are different from each other in some of the other coding sequencing termed as the polymorphisms, then you have different alleles for the same gene at the homologous chromosomes. So this is the difference between basically the loci, which are the regions, the genes which occupy those loci, and the alleles which differ by certain polymorphisms. So if we look at the gene structure in detail at the DNA level, so you have the promoter regions where the different transcription factors bind. You also have proximal to them the enhancer and silencer regions where regulatory proteins bind and can block or enhance the transcription of a particular gene. You have the 5' UTR region where the transcription actually starts, and then the coding exons as well as the intervening introns. And then you have the 3' UTR or the untranslated region. And obviously, once the mRNA is transcribed, so it contains both the exons as well as the introns, and these undergo a pre-processing wherein the mature mRNA only has the coding exon regions and has a 5' cap as well as a poly A tail for its recognition for transcription, for translation of the protein. So there are certain interesting DNA facts which I think make the topic even more interesting. So there are 3.4 billion base pairs in our human genome, which is huge. 3.4 billion means 3.4 into 10 raised to power 9 base pairs in the human genome, and around 20 to 25,000 coding genes in the human genome. The diameter of human DNA strand is only 2 nanometers. So it takes around 12,500 DNA strands to approximate the size of a human hair. However, if you have to put it lengthwise, the length of human DNA, that is all 46 chromosomes, stretched end to end is 6 feet. And the length of all the DNA, if we take it and all the cells in our body, is over 113 billion miles. So this is a huge distance if we put it for all the cells and all the DNA in our body. Another interesting fact is humans are 99.8% genetically identical. So if we are 99.8% genetically identical, the difference only remains in 0.2%. Now, if you do a 0.2% of 3.4 billion base pairs, you end up with something around 3.4 million base pairs. So 3.4 million means 3.4 into 10 raised to power 6. So this is the number of base pairs wherein you can have a polymorphism between me and you or you and another individual. So which becomes huge in terms of genomic information. So if you're looking at a whole genome sequencing and you're trying to see SNPs between me and you, so there may be around 3.4 into 10 raised to power 6 or 3.4 million different SNPs. Now, if we wish to start with the different genomic techniques, we should know in what should be our sample input, what we really are looking at, and then what sort of mutations are we going to see, because different sort of mutations, you have different techniques which are different sensitivity for detecting that particular type of mutation, and what is the spectrum mutations one can see, whether it's at the single base level or at the chromosome level. So initial would be our obviously starting material, which could be your DNA or RNA, which you extract out. The source can vary. It could be blood, it could be fresh tissue, it could be a formalin fixed embedded tissue, it could be a body fluid, it could be an aspirate, or it could be cells on a slide. And type of abnormality which we usually are looking at could be a numerical abnormality, that is change in the number, monosomy, trisomy, or polyploidy, or it could be structural abnormalities. Now, structural abnormalities can be vast. They can vary from a single nucleotide variations at the DNA single base level. And these are basically of two types: polymorphisms, which have a more than 1% prevalence in the population database, or they could be mutations. Now, mutations or single nucleotide variations could further be missense, that is synonymous, they are not coding for any protein, or non-synonymous, they are coding for a different protein. They could be nonsense, resulting in premature termination of the protein, or they could be splice site. Then you can also have small indels varying in size from 1 to 150 base pairs, and these indels can further insertion deletions can be in frame or frame shift type. Further, you have different sizes of the deletions, which can vary from short tandem repeats from 5 to 6 base pairs, or variable number of tandem repeats, to allo repeats, which can vary from 150 to 1000 base pairs. Now, you can see from single base pairs, you can have larger deletions. Then you go further, you encounter CNVs. So CNVs are basically copy number variations, which are usually defined as having a size between 1000 base pairs to 1.5 MB. And these can be large deletions or large amplifications. They are also termed as intermediate size structural abnormalities. Larger than these, from size 1.5 to 3 MB, usually you find the translocations and inversions, and they are also termed as large structure abnormalities. And very large are the ones which are more than 3 MB in size, or they are also termed as chromosomal size variations. So these are the sort of different mutations or abnormalities you can see in your DNA level. Then other than this, you can have epigenetic changes, and in these epigenetic changes primarily include DNA methylation or histone modifications or different miRNA expressions, and RNA if you are looking at RNA expression analysis. So this is a chart which will guide you or show you what are the different types of mutations which I discussed before, and what are the different types of techniques which can be used depending upon the size of the mutation. So depending upon the size of the mutation, you have different techniques which have different sensitivities. Not a single can detect all of them. They may be able to then, but then there would be certain limitations and certain different sensitivity to detect each of the different mutations. So if we start with 1 to 200 base pairs, so we can see here for 1 to 200 base pair short of mutations, which may be SNVs or small indels and deletions, you can use PCR based modification techniques like RFLP or ARMS PCR or real-time PCR. You can use Sanger sequencing looking for that smaller mutations, or for a targeted NGS panel, or whole exome and whole genome sequencing. For larger sort of deletions, for between 200 base pair to 1000 base pair, which are usually due to tandem repeats, you can do specific tandem repeat PCRs, which could be looking for short or long term duplications in that region. You can do a deletion SNP array, or you can even do whole exome, whole genome, depending upon the availability of the resource and the platform. For the larger, that is CNVs, or even larger sort of structure abnormalities from 1.5 to 3 MB, you have either MLP or FISH available to you. Even SNP arrays, they give you a very high sensitivity, ranging from certain 10 to 20 base pairs up to 3 MB. So SNP arrays have a huge spectrum. They can help you detect deletions from small base pairs even up to 3 MB in size. However, if you're looking at very large, more than 3 MB spectrum or chromosomal type abnormalities, then these are also termed as very large structural variations. Cytogenetics, conventional cytogenetics is one and first and foremost one. You can do array CGH, or you can also go in for whole genome sequencing. So how to decide what to use? But obviously it would depend upon what capital costs you can infuse and bring about, what sort of platform, what sort of sensitivity you are looking at in detection in different sort of mutations, what sort of throughput or turnaround time you're expecting, what sort of expertise or the molecular biologist or bioinformaticians do you have, and what is your recurring per sample cost. So all of these factors will help you decide which sort of technique you are going to use for a particular sort of size of mutation. So now we'll start looking one by one into the different techniques, and this is one molecular technique classification. There can be many others you can find in textbooks, but this is something looking at the targeting the single base level to genome level, which I find more relevant. And for if we look at the whole genome level, so you have conventional cytogenetics or the karyotyping, array CGH, and whole genome sequencing. If you wish to do targeted or some microscopic genomic abnormalities, then you have fish and microarray, which are also termed as molecular cytogenetics. If you need to do amplification based assays, you have the PCRs and their different modifications. And if you want to come down to single base level, then you obviously have Sanger sequencing and the targeted NGS. So we'll start with the conventional cytogenetics. So conventional cytogenetics or karyotyping. So it means in vitro clinical laboratory procedure which evaluates the chromosomes of a cell. So chromosomes basically, as we know, are individually distinguishable under light microscopy only during the cell division process, that is during the metaphase. So however, in cases of spontaneously proliferating cells, you may not require to culture them. So tumors which are highly proliferating, you can directly get a metaphase culture, or you can directly get a metaphase spread for those tumors. But in cases if you are looking at say inherited bone marrow failure syndromes like Fanconi's, or you're trying to do culture for slow growing tumors, then you need to extract the peripheral blood mononuclear cells and culture them in a particular media, and then prepare a metaphase spread. And the culture media which is most commonly used in conventional cytogenetics is the RPMI media, which is Roswell Park Memorial Institute media. You have the fetal calf serum and 5 to 30% percentage constituency, along with certain antibiotics and nutritional elements like L-glutamine. And what you do basically is you take the sample, which could be your peripheral blood or a marrow, and you try and culture in this RPMI media at 37 degree and a carbon dioxide incubator. Then you do a metaphase arrest by using a chemical termed as colchicine. This is followed by the hypotonic treatment, wherein you swell the cells using KCl, and then you fix them, and then you drop them from a particular height so that they break down and produce a metaphase spread over the microscope. Thereafter, you do a staining, GIMSA or other G banding staining to look at the different bands, and then analyze this spread by a karyotyping software or your own expertise, and try and classify them into different groups of chromosomes. So chromosome staining basically is based upon the percentage of GC and AT content in the chromosomes, and the dyes which are commonly used are the GIMSA or the quinacrine dyes. And G banding basically is highlights your GC areas light and dark bands, and Q banding highlights your AT rich areas. So the standard G banding technique allows around 400 to 600 bands to be visualized, but you have high resolution G banding techniques now available, which can give you more precise banding of your chromosome and more better classification of the different chromosomal subtypes. So different chromosomal abnormalities which can be encountered on conventional cytogenetics include the translocations. This can be reciprocal, where a part of certain chromosome goes on to another, and the other chromosome part comes to that chromosome. So these are termed as the reciprocal. You may have a Robertsonian sort of translocations, which are usually seen in acrocentric chromosomes, wherein the head ends of the acrocentric chromosomes, they fuse together. You may also have inversions which can be paracentric, not involving the centromere, or they can be pericentric involving the centromere region. You may find deletions in a particular region of a chromosome, or whole of the small arm, or even the whole of the chromosome. You may find duplications, or you may find ring chromosome formation, and you may also encounter fragile sites in chromosomes. So what is important to remember is the international system for human cytogenetic nomenclature, which is used to define the different chromosomal bands. So what you need to remember is that from centromere, there are two different bands in a chromosome arm. So one is your P arm or the short arm, and then the Q arm or the longer arm. And the different the nomenclature system starts from the centromere end towards the telomere end. So you have 1, 2, 3 different regions. So if this is a chromosome 3 and you are looking at the arm, that is the short arm P arm, so you'll write it as 3P. That is the first thing, chromosome 3 and short arm P. Then you are looking at which region? So you're looking at region 2, so that would come next. Then would come a sub region with that, that is the band. So the band, what is next is band 1 or 2. So if it's 2, you write 3P2 2, and then comes a sub band region. So sub band region is usually written after a dot, and that is how the nomenclature occurs. So you have the chromosome, you have the arm, then you have the particular region, then the band, and then a dot and a subband region. So that is how you define the particular band and subbands on a chromosome in karyotyping. So this is how a metaphase spread usually looks about. So you have different pairs of chromosomes there, and what you do is you place this plate of chromosomes or the slide into your karyotyping microscope and software. So it tries and classifies it into different chromosomes based on their size, their centromere location, and the band resolution, and it'll tell you as this is the pair 1, this is 2, this is 3, 4, and so on. So what are the reporting guidelines usually for karyotyping? So the material should best be collected in sodium heparin. At least 25 metaphases should be prepared, and at least 20 should be reportable. So 2 metaphases which show the same trisomy or a structural abnormality are termed as a clone, whereas 3 metaphases are required to show the same monosomy to be termed as clone. So this is important to remember, and the number of metaphases which show the clone are given in brackets in the end. So if it's a normal karyotype, or if it's with a structural abnormality, say 821, so you are seeing this structural abnormality in say 12 clones. So that is written in the brackets here. So complex karyotype is defined as presence of 3 or more abnormalities. And obviously karyotyping has a role to play in prenatal, birth defect, solid and blood cancers, where it tells us about the aneuploidies as well as different structural abnormalities. So this is the karyotyping, the software, which is, telling you the different chromosome pairs as highlighted based on the size, the centromere location, and the binding pattern. Then coming to the next part of the molecular cytogenetics. So I'll just touch the two important techniques here, the FISH and the microarrays, and what is the difference between comparative genomic or the microarray per se and the FISH technology. So we'll start with the FISH. So it's important to remember, first of all, the basic steps in fluorescence in situ hybridization. So you need to pre-treat or prepare your sample which you have to be using for FISH. So if it's going to be a smear or spread over a slide, ideal is to use lysine coated slides so that during the processing for the FISH, so your smear does not get washed off from the slide. If you are using FFP or fixed smear, then you need to deparaffinize in graded alcohols and in the incubator before you can start with the process. So this is all the input material you may have with yourself for FISH studies. And the first step per se involves permeabilization step, wherein in this material needs to be permeabilized for the probes or the FISH probes which are you are going to use. So we use primarily proteinase K or pepsin for the protein denatured protein and its digestion, and you use detergents like Triton X or NADS, which basically lead on to cell membrane holes and increase the permeability of cells. So denaturation then is performed for the genetic material, that is the cells on the slides, and then the probes are hybridized with it. So hybridization usually occurs overnight, and a hybridization solution along with the probes in a proper ratio is used. And then you wash and then mount and analyze under the fluorescence microscope for the signal. So this is briefly telling you about the different type of probes which are available. So you have gene specific probe, which are also termed as locus specific probes, which target certain loci over the chromosome arm or the particular genes. Or you may have centromere specific probes, which are very helpful in looking at numerical abnormalities. You have telomeric probes, and you also have whole chromosome painting, whereas you have probes for different gene specific probes for a particular full chromosome, and they help in highlighting or painting the full chromosome. So what is important in fluorescence in situ hybridization, especially connected with hematology, is the type of the probes which you are using. So you may have in a you may be looking at a single fusion dual color or a single fusion probe. So a single fusion probe is nothing but you're using, if you're looking at a translocation, you are using one probe which is proximal to that region of breakpoint and another probe which is distal to that region. And normally it would give you two signals separate for the regions on different chromosomes. But in case of a translocation, it would give a single fusion signal and two separate signals. However, if you are looking at dual color, dual fusion fish probes, which are more commonly used, especially in BCR, ABL or other fusion translocations. So here you are using a single color labeled probe both for proximal and distal to the breakpoint region, and another pair of probes proximal and distal to the other breakpoint region. And in normal cases, you will find 2 signals of each of these probes. But in case of a translocation, you will be finding 2 fusion, that is BCR ABL as well as ABL BCR. So this makes it more specific to detect the translocation. Then you may also have break apart probes wherein you are using different color probes, proximal and distal, for that particular breakpoint region. And normally they will get the signal close enough for the 2 colors. But in case of a translocation, this signal would be break apart or would come as separate. So what is important in fish reporting guidelines is that we need to define the different cutoff values for individual probes. So once you are starting with fish reporting, you get new probes, you need to test them onto different normal tissues, and you need to count the percentage of cells which are giving the abnormal signal. So signal which you usually will be found in an abnormal situation, but you're finding in normal tissues. So you'll need to count the percentage of cells which show that abnormal signal, and you need to calculate a standard deviation by running them on X number of normal tissues, taking the mean and deriving the SD, and then deriving your cutoff value, which would be standard deviation into 3. And the helpful guidelines for us are, if you are using a dual color single fusion probe, around 7%, dual color double fusion probes, it's around 1%, dual color break apart probes 3%, for centromeric probes around 5%. But you need to establish this all beforehand, starting with your the fish reporting in your own lab, that what particular cutoffs are you getting for that particular type of probe. And obviously low percentage of tumor cells make your fish interpretation very difficult. At times you may see the signals in fusion probes overlapping with each other, giving you false positive. Hence it becomes also more important to look at these cutoffs. At least 200 to 250 nuclei need to be screened, and signals below the sensitivity or specificity cutoff for the particular probe should not be reported as positive. So for HER2 new amplification, the reporting is 6 or more signals, and the ratio of HER2 to another probe, that is an internal control centromeric probe for chromosome 17, should be 2 or more. If you are doing NMIC amplification, 10 or more signal copies or more than 3 times control probe signals should be there. So this is based on interface fish reporting. For IM21, 5 or more signals, and with at least 3 or more clustered on abnormal chromosome 21 if you're looking at a metaphase. So this is how you try and report these amplifications based on fish. And if you look at here, this is a case of IM21. So you're seeing here the RUNX1 is with this red probe and your ETV6 is with the green one. So you're finding a clustered signal. So this suggests, so numerous signals clustered together in a particular region would suggest an IM21. And this sort of pattern where you're getting extra signals of IM21 but they are not clustered together would rather suggest you a hyperdiploidy in a case of BALL and not IM21. So this is something which is false positive. You don't need to call this as IM21. If you're looking at a metaphase spread, again this is some sort of a normal signal where you're finding 2 signals for RUNX1. But this sort of clustering for RUNX1 on a chromosome 21 would suggest in a metaphase as a IM21. Right. So next, moving on to the next technique, which is microarray. So there are different terminologies which are being used with microarray, and I've seen many students coming to me quite confused which sort of terminology to be using for what particular technique of microarray or what particular platform we are using, then what to call that particular testing. So microarray basically involves 2 different parts. So one is your chromosomal or cytogenomic microarray, and the other is DNA microarray or gene expression profiling. So in chromosomal or cytogenic chromosomal microarray, the input is going to be your DNA, whereas in your DNA microarray or gene expression profiling, the RNA transcribed into a cDNA is your input material. Now, what is done is this input material is hybridized to probes which are already present on certain chips or slides provided by the different platform manufacturers. And these probes basically could be cDNA probes which are complementary to your this DNA or this RNA or cDNA here. The cDNA probes usually are larger in length, 100 to 1000 base pairs, or you may have oligonucleotide probes. So most of the platforms today usually in silico synthesized oligonucleotide probes over your chips. So these are usually short, ranging in size from 25 to 50 base pairs, and they span the different length of the human genome or your target region. So where do you really use your chromosomal or cytogenomic microarray? It's very helpful in detecting your copy number variations, which I told vary in size from 1000 base pairs to up to 1.5 MB. That is the intermediate size deletions, duplication or gains. It's also helpful in looking at loss of heterozygosity, uniparental disomy, especially if you are getting long stretches of homozygosity on a chromosome, or looking at low level of mosaicism. On the other hand, your RNA or gene expression profiling will help you in differential RNA expression in control versus a disease or control versus a tumor sample, help you in class prediction that this particular RNA signature gives you this grade of tumor or this class of tumor, or may even help you in class discovery, that is this subset of a particular tumor is showing this different gene signature. So that is how you classify mRNA. So if we look at the chromosomal or the cytogenomic type of mRNA, so we have two common platforms which are available with us. So we have the Affymetrix, which is usually termed as the gold standard, or the Illumina platforms, which are single channel microarray platforms. And on the other hand, you have the Agilent and the Roche platforms, which are usually double channel. So the Agilent and Roche double channel platforms, the chromosomal microarray which you do is usually termed as array CGH, whereas on the Affymetrix and Illumina single channel platforms, it's usually an array SNP, which is usually performed. So difference between them is that in array CGH you need a normal along or a normal or a control or a reference sample along with your test sample. You label both of them with different dyes. In this case with the cyanin 3 for a green dye and cyanin 5 for a red one, and then you mix them in equal ratio 1:1 and hybridize them to a chip, as I told you, which already has oligonucleotides or cDNA already plated upon them. And then you look at what is the ratio of the signals, whether green is more, where red is more, or it's a yellow where both of them are equally hybridizing, and accordingly define the deletion or amplification and gains in that particular case. Whereas in array SNP, you only require a test sample, you don't need a reference. So you label it with the biotin probes and then hybridize them with the different a chip. You have to use a single chip for a single platform, since it's a single channel the instruments. And then what happens is the reference sample for them is a database of genomic copy number variations, which is already there. So they put up your sample and correlate with the database available, reference database available, and then give you the call of the copy numbers in your test sample. So that is how this is the difference between these two platforms, and this is how the reporting usually is done. So if you are finding after a scan a region which is showing a sort of a yellow spot to you, basically it has two normal and two copies in your patient disease or a tumor sample, and the ratio is 1:1. However, if you're finding green more, so there's more of the green label from the patient sample and less from the red sample, so you're finding an amplification or gain. So if you are finding the red sample, that is the reference copy number more, then you're finding a deletion in your test sample. So that is how it is compared and reported. So these are the basic steps of a CMA. So you do a DNA digestion, ligation amplification, followed by the fragmentation of that DNA, and then labeling. So if you are using a single channel, you label it only with biotin probes, and then hybridize it to the chip available, and then scan the data. On the other hand, if you are doing DNA microarray for gene expression profiling, then you have, you need to obtain RNA as the input sample, as I told. Then you transcribe this RNA into cDNA, and then you label them. If you are using a dual channel chip from Agilent, then you use two different colors and you require a normal or control sample. If you are using an Affymetrix, you can use their gene expression chip and you can just label by biotin. So in double labeling, the gene expression is done with the expression of particular genes in the patient sample as compared to the control sample. Whereas in Affymetrix, it's usually, the perfect match probes related to the background noise. So that is how they report out the gene expression. Right. So coming to the next technique. So this is something which is basic to rather all the techniques. So if you are using Sanger sequencing, you are using NGS, you are using, even micro or anything, you will be doing PCR. So PCR is not a separate technique in itself, but it is basically, it's a technique whereby you amplify the DNA material. So this amplification step is going to be there in different genomic techniques. So PCR basically forms the base of many other techniques. So PCR step would be there in all these different techniques, and this was discovered way back in 1983 by Carey Mullis. So, and the steps, as we all know, the basic steps of PCR, you have a denaturation, then annealing of your primers to the different regions, followed by extension. And you require, these different components for doing a PCR. So your input DNA material, your primer pairs, which you have devised for a particular target sequence, your different nucleotides, the tag polymerase of DNA, the buffer which would be required containing magnesium chloride, other things, and a PCR tubes. So your nucleotides, buffer, and tag polymerase, you can find in a master mix, especially the not the tag polymerase, but your buffer and nucleotides and all are available together as a master mix, but you need the tag polymerase and input DNA material separate. And what is important is how you design the primers. So primers basically are usually 17 to 28 base in length. And this is very important here, because if you are getting just a very why this 17 or 28 base pair length is chosen, because this 16 or 17 base pair will give you so high specificity that the finding of a similar target of 16 to 17 base pair here anywhere in your whole human genome is very, very rare. The chance is 1 in 4 billion, so which is null, considering 3.4 billion base pairs in our genome. So that is why you keep a target length of 17 to 28 base pair, increasing the specificity of primers. And while designing a primer, you should remember that the content of GC should be around 40 to 60%. Optimum temperatures for the primers between the forward and reverse primers should not be more than 2 degree, and it should be between 55 to 66 degree for each of them. So 3' end of the primer usually contains the G or the C regions, and you have to avoid repetitive bases in the genome, but because they make the binding of primers difficult. And you also have to avoid mismatch between primers and template, especially at the 3' end. So these are certain principles which you have to keep in mind while designing primers for a particular target region. So these are the steps for PCR, which I think all of you know. And for setting up a basic PCR lab, so you definitely require a basic PCR. You also require gel electrophoresis system and a viewing UV transilluminator. So this is how you set up the gel. So this is 2% agarose gel, and then you load your sample, run it on the gel, and then you look on for the different bands in a UV illuminator. So important to remember here is a single precise band for DNA at the precise location as per the ladder run is what is expected. But if you are finding a band somewhere here, so this usually suggests you above that region of your DNA of interest, then it's a possible protein contamination. If you're finding it below it, it's an RNA contamination. If you're finding your DNA band itself smeared out, that means your DNA is degraded and not of good quality. So there are different PCR troubleshootings available. So I'll not go into the details. And this is all the basic equipment which you need to set up a small PCR laboratory, which includes PCR cabinet, the machine PCR, and electrophoresis as well as UV transilluminator. So different modifications of PCR are available. I'll not go into the details of them. So you have reverse transcriptase PCR, which is basically nothing but transcribing, taking out your input material RNA, because there's no PCR which can amplify the RNA directly. So you need to convert it into a cDNA, and you use an reverse transcriptase enzyme. The common ones which are used are AMV reverse transcriptase or MLLV. You can have multiplex PCR modifications wherein your primer sets for different target regions you have standardized and they work or anneal on your target DNA at a particular similar temperature. So say around 58 or 59 degrees, all these primer sets are excuse me, please, can you mute?
This is the first time I'm traveling alone.
Excuse me, can someone mute? So in multiplex, you are having different primer sets which are binding at a particular temperature, and then you can put them together in one vial, and they'll anneal at that particular temperature and can give you multiple bands at different sizes as per your requirement. In a nested PCR, basically you are using two different primer sets. One is which is a non-specific primer which will amplify your target region, and then you have a specific primer set which will bind within the target region, increasing your specificity. Allele specific or AIIMS PCR are where you are using again two sets. One is for a common internal gene located near your gene of interest, and another is your target which you have two different set of primers, one for the mutant the change at level, one for the wild type. And then you try and look at what sort of bands, whether they are wild type, heterozygous or homozygous on the gels. Gap PCR, which is commonly used for large deletions, especially in alpha thal. Here you are making primer pair also for the deletion region, and in wild type this would give you a smaller band that is around say 194 in alpha thal deletions. And if your deletion is present, so this primer won't bind and won't give you a band, but you will get a larger band of around 550. So that is how you devise primers for large deletions. RFLP PCR, we use the restriction enzymes. These are nothing but endonucleases. These are derived from bacteriophages, which protect the bacteria from infestation by a virus and degrade the virus genome. So these restriction enzymes are different, and their difference is based upon the particular target region, that is the nucleotide which they'll target, whether it's a G or C, or whether it's a GATC sequence or whatever sequence where they are going to identify and cut. So that would be the specificity for different RFLP enzymes. So what is important in principle to remember is that for a particular mutation, a region may, that particular mutation may lead to creation of a restriction site or may lead to abolition of a restriction site at that particular area. So if it leads to creation of a restriction site and you amplify that region and then expose it to the restriction enzyme, you will find two different bands. But if it leads to abolition, so you will find a single band after exposure to the restriction enzyme, and accordingly you can look at whether you are finding two or single bands along with a wild type band, then this is a heterozygous, or else it's a homozygous. Then you have the RQ-PCRs, which basically use different probes. The CyberG probe binds to the double-stranded DNA, whereas the Tagman probes usually have a fluorescent dye along with a quencher dye. And your DNA tag polymerase, as it extends upon, it removes or causes hydrolysis of this probe, Tagman probe, results in the relation of this fluorescent dye from the quencher dye and a signal. So this increases the specificity of detection of your target region, and different fluoropores and quenches are highlighted here. So what's important to remember is you'll get a particular cycle threshold in particular cases, that is where your fluorescence starts to rise above baseline region. So this is where you're probably trying to see the amplification of your target region. So you can do two different types of quantification in real-time PCR, the relative and absolute. For absolute quantification, you need to derive a calibration curve and you need a standard. So for example, if you're using for BCR-ABL, so you need a standard that already says that this plasmid contains 10 raised to power 6 copies of BCR-ABL. So you dilute them from 10 raised to power 6 to 10 raised to power 1. You run a calibration curve, you'll find different CT values. Then you run your test sample, and based upon the CT value, you can put it and go on to the graph of the standards, and you can calculate the amount of BCR-ABL copies that will be there in your sample. On the other hand, in relative quantification, we take internal control gene. For BCR-ABL, we take ABL1, and we take a positive control sample. So in both a positive control or a reference sample, you will do BCR as well as ABL, and in your target sample, you will do both. And you will calculate the CT for both, that is internal normalization of your BCR-ABL with ABL in both. And then you will do a delta-delta CT, wherein you will normalize your target sample with your reference sample. So you'll minus delta CT of target minus delta CT of reference. And then you can do a relative expression by 2 raised to power minus delta delta CT method and tell what is the difference in the amount of a particular mRNA as compared to the reference or positive control or control sample. So other than this, the technique which is used for CNVs very commonly is the MLPA, which is multiplex ligation probe amplification assay. Herein two different probes are used which bind to your target's region, and then by a ligation PCR these are joined together. The difference is that one of the probe has a stuffer sequence, and this stuffer sequence, as highlighted in green here, varies in length in different probes. So this varying length of the stuffer sequence in different probes gives you different resolution on the capillary electrophoresis when you try and separate your test fragments. So based on the size of the stuffer fragment, each of them will give you a different peak. And once you compare these peak with the normal probes as well as a normal sample copy numbers, that is how you report out the dosage quotient for your particular test sample. So in this particular case, you're finding all the probes are having a copy number of 1, So there's no deviation, so there's no deletion or amplification here. Whereas in this case, you're finding a heterozygous deletion, wherein you're finding two probes which are not binding appropriately and giving you a low copy number of 0.5. So these are available from MRC Holland. If you go to their site, you will find MLPA kit for different CNVs and different genetic disorders as well as cancers, and you can take that kit. You can do the MLPA in house. You require a PCR machine and you require a capillary electrophoresis system or a Sanger system, and then you can analyze the result by a cough analyzer software, which is available free of cost. These are basically now obsolete techniques, rather northern and southern blot. Western blot is still done to look at the protein expression, and so I'll not go into details of these. I'll come lastly to the sequencing technologies looking at the single base level. So we have the Sanger sequencer as well as the next generation sequencing. So the Sanger sequencing is also termed as sequencing by synthesis, and it's also termed as dideoxy chain termination method. Whereas the next generation sequences are second generation and third generation sequences. So the second generation, two commonly available technologies are the Illumina and the Life technologies, that is the ion torrent. The Illumina does sequencing based on the principle of reversible terminator, whereas ion torrent is totally natural chemistry based on the pH and HIN release. Then you have the third generation or direct sequences like nanopore, which directly sequence your libraries prepared, and you don't need to create clonal amplification templates. So what is the sample flow if you are looking at Sanger sequencing? So if you are going to do Sanger sequencing in a particular case, so what should be your sample flow? So basically you'll need your EDTA sample, which can be 2 to 3 ml. So if you're looking at cancer, so this needs to have leukemic blasts or cells, or otherwise you can separate the PBMCs from this EDTA sample, and you require HiPAC or sedimentation gradient media. And this sedimentation gradient media is used in a you dilute your blood and use the media and centrifuge at high speed for 20 minutes. You get separation of your blood components in different layers, and what is most important is this white layer of PBMCs which you need to extract. So these have your peripheral blood mononuclear cells, and this is the one which we usually extract our genetic material from, that is DNA or RNA. You extract that either manually using kit Skygen or by whatever automated platforms you have. Then you go for the PCR of the target gene, the exon or the mutation, whatever you are looking at in your particular case, and you perform the PCR. And after PCR you run the gel. You see your product, whether your particular product is there. If it's there, then you purify your particular product. So purification is usually done either by chemical or magnetic methods. So exosap is one chemical which is commonly available, and basic principle is that you need to remove the inhibitors and salts which are used during PCR, so that your sequencing data is much clean and much better. And after purification, you submit it for sequencing. Now in Sanger sequencing, this is what traditionally was used. The principle basically is that you are using dideoxy nucleotides along with the normal nucleotides. So the normal ACGT are the nucleotides which are there, but then you are using dideoxy or irreversible terminator nucleotides which have a dideoxy group, and if they bind in particular area of a sequence, so they will not result in further addition of more nucleotides there, and you will find that length of the particular sequence, and then in further cycle that particular length will get amplified, and in different cycles you will find the different dideoxys binding at different levels and different lengths of sequences being formed. Then you run them on electrophoresis system. So basically electrophoresis system have capillaries and a polymer gel. So once fragments are run on that, the fragments which are the smallest size, that is the dideoxy has bound to just at the first step, would be the smallest one. So they would be the fastest to run on the gel. So they will be somewhat down below. So you read that gel from down below to up. So this was what was conventionally formed. So down below to up, you try and read, and you'll get your sequence complementary to it. But now what is we have available automated capillary electrophoresis systems. So these are the automated systems which are available in market. This is the 3500DX from Thermo Fisher. This is the new Seek Studio, and this is from the Promega one. So these already have an inbuilt 4 or 8 or 12 capillaries, and these capillaries you just have to insert the polymers and prepare your sequencing reaction using sequencing the dideoxynucleotides and the polymerase, and then put them up into this chamber. So this will the capillaries will go down and will take up your sample, inject them onto the polymer and run them. So the different fragments will pass through a laser. So the laser will strike and produce different colors for depending upon which dideoxy they are encountering, and you get the electrophorograms for different labeled nucleotides as here. So if in a proband you're finding a change from G to A, so in normal G at this particular position, which was labeled with say black color dye and giving you this sort of electrophorogram, and in proband you are getting an A here, which is a single peak of A. So this means the proband is homozygous for this G to A change. So you do a segregation analysis in the mother and father, you find mother and father both having both peaks for green as well as A, your black. So suggesting both G and A are heterozygous in mother and father. So that is how you look at the Sanger sequencing data. So I was using big for because limit and sensitivity of your Sanger sequencer was almost 15 to 20%. So this means that you need to have the mutation frequency in your cells more than 15 to 20% of your cells must show that particular mutation or that particular change. Otherwise, your signal in Sanger sequencing technology gets lost in the background signal. So if you'll find, say cell, if you're looking at LCH and you're giving me a cell block which has, the tumor cells for LCH as well as admixed with inflammatory cells, and I'd get a sample with tumor cells being just 10% fraction. So the signal from Sanger machine would be so small a peak if there is any change in BRAF gene. So I'll not be able to pick that up in confidence and say this is the true peak of a mutation or whether this is a noise. So this is how NGS came and resolved the sensitivity. So it can go down to the level of 1% or 2% clonal fraction. And obviously you can, it's a very high throughput technique. You can do multiple targets, multiplexing in one go. You can look at many large number of genes rather than looking at one gene or one exon and one particular target in a Sanger sequencer. The sample inflow in NGS remains the same. So you have the EDTA separate out your cells, you go about and extract the nucleic acid from them. Then you have to perform a quality check. So quality check depends upon which platform you are using. The common ones are Qubit. For ion torrent platforms, you have Bioanalyzer, you have Tape Station and other quality check measures. And once your input DNA is between 10 to 100 nanogram, then only you can proceed further for your downstream NGS experiment. You start with, there are basically 3 steps. The library construction is the paramount step. So you have 2 different PCRs during library construction. And then you do a template generation, which is done in the form of microspheres on ion torrent and flow cells on Illumina. I'll show them briefly later. And this is followed by the sequencing on the particular platform. So you can divide these steps as the wet lab steps, which are basically library preparation, the template preparation and sequencing, and then the bioinformatic part for the data which comes out after the sequencing. So that bioinformatics is primary, secondary or tertiary analysis. So in library preparation, if we briefly look at, so there are basically 2 main principles if we are trying to do targeted NGS. In targeted NGS, we are looking at multiple genes or certain targets in our genes. So you have hybridization based capture, you have amplicon PCRs. So in what this is, if you are using amplicon PCR, you are amplifying your target upfront. In hybridization capture, you are capturing your target upfront, and then you are adding certain adapters or barcodes to make a library so that this is recognized as a separate sample and has certain regions wherein clonal amplification can be done later. So once this library is prepared, you clonally amplify it by attaching it to a support media. So that support media can vary depending on the platform. In ion torrent, these are small beads or microspheres or ion spheres, and in Illumina, it's basically on the flow cell lawns, termed as bridge amplification. Thereafter, you load it onto the flow cell or the chip and then perform your sequencing. So in Illumina, as I told, it's a reversible terminator sequencing. So you have your DNA, you share it. So you can also do hybridization based capture. So different kits are available for different methodologies. So you can use a hybridization capture kit for target sequencing on Illumina. You can also shear or break it, fragment your DNA using chemical methods, that is transposomes, that is, these are enzymes which cleave your DNA at specific intervals, 100 or 200 base pair, or you can use physical methods like covariates or biorupture to break down your DNA and then select your size fragments and then prepare a library by binding the adapters or the barcode regions and then load them onto a flow cell. Onto a flow cell, there are already complementary regions to the adapters. So these adapter regions, you already have a complementary regions bound to this flow cells. So your fragments, whatever have been prepared, will bind to these complementary regions and undergo a bridge amplification, forming clusters. Now these clusters are which are then sequenced in the Illumina platform, and this is done by reversible terminator sequencing. So you have all the nucleotides, 4 nucleotides, which are labeled, each of one them is labeled with a different fluorescent dye and with a reversible terminator sequence. So if there is an A here, so the T, if it comes to bind here, so it already has a reversible sequence attached to it. It won't allow another base pair binding there. So why it doesn't allow? So that it gives time for the laser to strike the particular fluorescent dye and result in a signal which can be captured. So once that is done, then this reversible terminator is removed and the next nucleotide can bind to its complementary sequence, and that's how the sequencing occurs. Whereas in ion torrent, you have a little different, you have an amplicon sort of PCR upfront wherein you amplify your target regions by using primer pairs which you have synthesized and procured from the company, and these primer pairs can come in multiplex tubes. So you have to perform 1 or 2 PCRs to multiply or amplify your target region for thousands of genes, and then you add the adapters and the barcode regions and amplify your library. After that, you have to do a clonal amplification. As in Illumina, it was done on the flow cells in the form of bridge amplifications. In ion torrent, it's on the beads. So these are ion sphere or beads which have complementary regions to your adapters on the targets, and they bind your target product, and you amplify as an oil in water emulsion, and you get a conal amplification of your product on the bead, and then you go load it onto the chips. So these chips have millions of the well, and each well will capture one of your ion sphere, and then you put in your sequencing reagents. So the sequencing reagents will open the DNA, denature it, and one by one attach a nucleotide. So if there are complementary nucleotide binding, so what normally happens is there's release of H ion during binding of one nucleotide to another. And this H ion which is released is captured by the thin layer of pH sensors present below the chip wells. So each well has one small pH meter below it. So it's the smallest pH meter below each well, and it will capture any H ion released and produced an electric gated signal. So this signal is then converted onto the the complementary base which was flown in during sequencing. So in ion torrent case, it's totally natural chemistry. You are not finding any fluorescent sort of dyes or fluorescent material being used. Secondly, all 4 nucleotides are not flown in once. It's in a particular sequence, each nucleotide goes into this well. So maybe T is going first, then C is going, then G. So if T produces a signal, you know that it's A in the sequence. So that is how it is recorded. Whereas in Illumina, all the 4 nucleotides in one flow because they are labeled with different fluorescence. And what you get out is the reads. So this is the output of an NGS sequencing reaction. So a read is nothing but a single uninterrupted series of nucleotides and representing the sequence of the template. So you may have this is termed as the breadth of the coverage, and the coverage means the fraction of genome which is sequenced by at least one read. Whereas if you look at the depth, so this is the depth. So if you go it vertically, it's the depth. If you go horizontally, it's the breadth of coverage. So that is the difference between both things. So different NGS technologies are there: whole genome, whole exome, and targeted. So each has its own merits and demerits. Obviously, if you are going in for whole exome, whole genome, you are increasing the amount of data which is going to come out. You are increasing the amount of complexity which you are going to encounter. Your depth will reduce because you to produce such high data and depth, you will require much more, you can pool in less number of samples, so it isn't cost effective. Whereas in targeted, you can get a huge depth. You can look at particular sequence of interest which you need to look in, and you can report it in a early turnaround time. And obviously you need to know a difference between what is a somatic and a germline mutation. So somatic mutations are those which are not present in your reproductive cells and are acquired later in life and usually related with cancers. They might be related with certain, inherited disorders when they are termed as de novo mutations. On the other hand, the germline ones are which are present and inherited from your inheritable within a family and are present within the reproductive organs. So this is the bioinformatics pipeline which is used. So you find your data from NGS in different file formats. The bilkul raw data is the FASTQ, and then you have aligned data in SAMBAM format and the variant calling format for the variant called data. So I'll stop out here and thank you very much for your attention.
Dear audience, dear audience, I just want to announce that our Dean Academics, Dr. Sanjay Vikrant, has joined our meeting, and I wholeheartedly invite Dr. Sanjay Vikrant to address the meeting and gives the words of encouragement and shower his blessing. Dean sir, unmute him. Sir, kindly unmute yourself.
Hello.
Yes, sir.
First of all, I would like to congratulate Dr. Pratik Bhatia for a wonderful presentation, especially the way he has explained chromosomal microarray was very enlightening. And I would also like to congratulate AIIMS Bilaspur for a wonderful CME. It was very encouraging and very enlightening. And thank you, Dr. Pratik.
Thank you, my pleasure. Thank you.
Hello, Dean sir. Am I audible, sir?
Yes, yes.
Sir, please kindly give your.
Yes, yes,
Sir,
you are audible. Am I audible?
Yes, sir, your video is not coming, sir.
I'm audible.
Yes, sir. Yes, sir.
Okay. So, good afternoon, all. I welcome all speakers and chairpersons and delegates for today's CME on update on molecular pathology, which is very important topic in today's era of modern medicine. Molecular pathology is among the most that is highly complex disciplines in modern medicine, and in fact that has made its development both long and arduous. It is my pleasure to see speakers and chairpersons from the tertiary care institutions of the country like AIIMS Delhi, AIIMS Jodhpur, BGI Chandigarh, Tata Memorial Hospital Mumbai, and Government Medical College Sector 32 Chandigarh on the same platform. I hope the audience will gain a lot from all the sessions given by such dynamic and knowledgeable speakers. I congratulate Department of Pathology, AIIMS Bilaspur, for organizing this program, and I wish them luck and wish this event a success. Thank you.
Thank you so much, sir. Sir, sorry for the interruption. Now coming back to the session. Sir, you have beautifully elaborated. Pratik, sir. Am I audible, sir? Sir, you have beautifully elaborated all. You have beautifully elaborated all the techniques, and mainly you have highlighted the main basic steps that is required for all kind of molecular techniques. Thank you so much, sir. Now I request our chairperson, Dr. Anita Tegan, to kindly express your views.
Thank you. Am I audible? Thank you, Manupriya.
Yes, ma'am.
Thank you, Manupriya and her team for giving me this opportunity, and you're doing a wonderful job by organizing this. I think Pratik has done an excellent job. He's managed to compress a lot of important information and put it simply so that everybody can understand. Excellent, Pratik. You've done a wonderful job.
Thank you so much. Thank you so much. My pleasure.
Now, our second chairperson, Dr. Pulkit Rastogi, can you come on the screen?
Yeah, am I audible?
Yes, sir, you are audible.
Yeah, so I echo the words of Anita ma'am, and sir has definitely very wonderfully comprehended all the aspects of molecular pathology, the basics. So basically, so as you have seen in the previous lectures, that various terms have been used. So he has clarified each and every term and how we approach, how we test those various molecular assays in our lab, and how can we carry forward from the basic test to the higher end test. So it was really very interesting, and it is always interesting to listen to sir. And yeah, so it is a great CME, and I congratulate Dr. Manupriya, Dr. Gurvinder, and whole team of AIIMS Bilaspur for organizing this wonderful CME. Recently, I had been to the campus of AIIMS Bilaspur. It is wonderfully located, and I heartfelt, I extend my all the best wishes for its further progress, and that's it. So
Thank
over
you
to
so
the
much for your comments. And Pratik sir, there is a one question from the audience. Dr. Pravesh Dhiman sir has asked, does FLT allelic ratio currently used for risk stratification?
So yes, so if you are doing in a lot of AML related work, so FLT3 is a very important marker, and FLT3 allelic ratio is something which is being utilized and for not only for prognostic but even for therapeutic in the West. So it's limited to trials currently in the West for therapeutic purpose, but definitely for prognostic it is being used. So you have different methods or techniques by which you can look at that. So NGS is one, but best is doing a gene scan, which you told. So the gene scan is basically using your Sanger system, wherein you can look at the different peaks for FLT3 clones, and you can find even multiple different sized clones or different amplification clones in a single case, and all that can be visualized on a gene scan, and you can look at the height of that peak and compare it with the peak of the normals and try and bring out the allele ratio. On the NGS other hand, what you get is usually a variant allele frequency. So NGS will tell about you the size of that particular clone. It will also tell you the multiple clones if they are present, and that would be in the form not of a ratio but as a variant allele frequency. So the size of the clones also matter. What is important to remember about FLT3 is that it's not a very good MRD marker. So you need to detect it upfront in a particular AML case to take a decision about the prognosis. But to make it as an MRD marker, it's not a good marker because FLT3 expression, even it evolves during the time of therapy within a AML. So you find new clones coming up, you may find the same clone going down, and its size increasing changes. So you can't have it as a good marker for MRD purposes. In that particular case in AML, NPM is a better MRD marker if you find it positive upfront.
Okay, thank you, sir. I hope Dr. Pramesh Diwan has got her answer. And now I invite Dr. Manupriya for the session. Okay, so now completing our CME. Now we have a wonderful session on the molecular pathology, and many distinguished speakers have talked on the upcoming topic, that is on molecular pathology. I have a proud privilege to give the vote of thanks to such an august assembly. So first of all, I would like to thank our worthy executive director, Dr. Veer Singh Negi, for patronizing this CME and for providing us immense support for conducting this program. I would also like to express my thanks to our Dean Academics, Dr. Sanjay Vikrant, for their immense support and for continuing this program. My sincere regards are and thanks to all the distinguished speakers who have spoken in this online forum and have educated us immensely, because this is an upcoming topic, clarified our ideas on them. And my sincere and humble thanks to the distinguished clinician and pathologist who have been chairing the session, moderating the talks and inciting the audience into the healthy and fruitful discussions. And so I would like to thank our residents, our MBBS students who have been pivotal in making this CME successful along with their enthusiasm. I would like to express my gratitude to our technical teams for their thorough support and for the necessary event management. As we are a new institution and our Department of Pathology is comprising of me, my senior Dr. Manupriya Sharma, who is Associate Professor and also our Head of Department of Pathology. I would definitely like to thank Dr. Manupriya Sharma for her excellent approach and her knowledge and skills. In addition, I want to thank my colleagues, Dr. Shushma Bharati and Dr. Ekta, not only for supporting for my CME, but also for raising this department. Then I would like to express my immense gratitude to all the people who have attended the talk, who have questioned, shared their own experiences with the speakers and with us. I would like to express my gratitude towards the audience. And last but not the least, I want to thank to the patients, the benefit of which is our primary motto, and the treatment, the management of these patients actually make us understand the difficult topic, and they are our inspiration. So at the end of this session, I would like to thank our patients for inspired us to learn more, to treat and to manage the disease. Thank you so much. So now we'll share the link for quiz for the students, and just go to the emails, just check the link, and this will start. This will for 30 minutes. After that, that link will be, get off closed. Thank you so much.
देखो स्टार्ट हो गई।
ऐसे ही नहीं है, चल रहा है, ये कि खत्म है, अभी चल रही है मीटिंग, ये भी तक चल रहा है। हाउ पता नहीं सन्नू की ये किसने बोला कि 26 को हो रहा है? मुझे तो यही डर लग रहा था, परसों होगा तो आते ही तहलका मचेगा। फाइनली हेलो मुन्नी तेरी आई कदी तक की, कब तक है तेरी? चुपचाप आई है 25 को ना वापस, एक्सटेंड उक्सटेंड नहीं करना ज्यादा, ठीक है ना? नहीं तो फिर हम तेरे को करेंगे ठीक। आती नहीं है जल्दी, फिर उसके बाद छुट्टियों पे जाना ना ऑफिशियली 1 महीने की, है ना? ठीक ठीक रहना बढ़िया अपने आराम से, टेंशन बस तो फ्री माइंड, वो आपका ख्याल रख लेंगे दोनों का। नहीं तब अच्छा है। मैं ना परी देख के आती हूँ, मेरी जी की हुई है, उसने नहीं भेजी हूँ, चलो उसकी डेट हुई 15।